Call to order. Good morning and welcome to the third meeting of the Nevada State Silver-Haired Legislative Forum. First, we will call the roll. For those members attending virtually, would you please turn on your cameras and respond when you hear your name? Madam Secretary, please call the roll. If a member is not present, please record that member as present when he or she arrives.
Ms. Lucille Aiden. Here. Ms. Dottie Ahrens. Ms. Joanne Bongiorno. Mr. Jack Ginter. Dr. Marilyn Jordan.
Present.
Ms. Lisa Laughlin.
Present.
Ms. Laura Levitt. Ms. Peggy Levitt.
Present.
Ms. Mercedes Maharis.
Present. We're working on the video that it's not accepting, but I can hear you.
Dr. William Marchant.
Present.
Ms. Terry Robertson. Ms. Betty Rumford. Mr. Fred Silberkraus. Mr. Roger Troth.
Present.
Ms. Rosie Tyler.
Present.
Dr. Austin Wand.
Present.
Ms. Valerie Woods. President Fran Alvarez.
Present. Madam Secretary, please indicate forum members Valerie Woods, Betty Rumford, Doris Aherns, and Terry Robertson are excused. Welcome to our audience in Las Vegas and to those joining us by video conference in Carson City and anyone listening over the internet. Before we begin, I would like to take a moment to go over some basic housekeeping items. Our meeting is video conference to Carson City. You can virtually participate over Zoom as well. I am asking our presenters on the Zoom video to call to leave your cameras off and microphones muted until I call up the agenda item under which you will present, or if I direct any questions to you. The Zoom video call has a chat feature. However, this feature is only to be used for technical assistance. Any links or information that you would like to share during your presentation should be stated verbally on the record. Members of the public should sign the sign-in sheet at each location, even if you do not intend to testify. When testifying, please remember to turn on your microphone and clearly state your name and the entity you represent at the beginning of your testimony. Speak directly into the microphone to ensure those listening in other locations and watching online can hear your testimony. Please remember to turn the microphone off when you finish speaking. Each witness should provide a business card and a copy of any written materials not previously submitted to the Secretary. Meeting materials provided to forum members for this meeting can be accessed on the forum's webpage. Individual public copies are also available in each meeting location. Anyone who would like to receive electronic notification of and access to the forum's agendas, minutes, and final report can do so by going to the Nevada Legislature's website and following the links. And finally, I would like to remind everyone to please silence all of your electronic devices, especially cell phones and laptops, during the meeting. With that, let's get started. Agenda item 2 is public comment. We will have a public comment period at the beginning and end of the meeting. Speakers are urged to avoid repeating comments or points made by previous speakers. Any person may also submit written comments to the Forum Secretary during or after today's meeting. In addition to testifying in person, members of the public may provide public comment in 4 different ways, all of which are listed on the agenda. With that, we will move to public comment. Members, please keep in mind that public comment is only for members of the public. We will start with public comment from those in the physical locations and then move to public comment from anyone who has called in. Is there anyone in Carson City who would like to provide public comment at this time? Seeing none, is there anyone in Las Vegas who would like to provide public comment at this time? Please step forward.
Good morning. I am Tony Arcadapane, and I am a doctoral candidate in public policy at UNLV. My area of focus details the impact of long-term care costs on middle-class seniors and families. In addition to my personal experience navigating long-term care in Nevada, I have spent the last 2 years researching this topic. There is a crisis in America, and Nevada is not immune from this crisis. This crisis impacts the forgotten middle class and how they will pay for long-term care costs. Research shows that this group gets ignored and underserved in today's long-term care market, and it's a problem that is going to explode over the next 20 years. There is a natural tendency to believe that you will always be able to maintain your independence and take care of yourself and your family. However, at least 70% of the population will find themselves or a family member needing some type of long-term care and facing the struggles of paying for this care. That means that approximately 11 of the 16 people in this meeting today may need long-term care in their lifetime. In addition, many Americans do not know what long-term care includes, or they mistakenly believe Medicare or their employer or private health insurance will cover these costs. Unfortunately, for some seniors, living a longer life comes with an increased opportunity to experience medical conditions that are more prevalent as people age. Health challenges may range from limited movement to more serious health issues such as diabetes, severe injury, and cognitive issues, to name a few. These conditions may result in the need for some form of long-term care. The decrease in long-term care insurance policies being purchased, the misunderstanding of who pays for long-term care costs, and unaffordable long-term care insurance premiums have resulted in many middle-class Americans being unprepared and unable to cover these care costs. There are some funding options available to assist with paying for long-term care costs. However, most have strict income requirements, making them inaccessible to the middle-class senior. As of 2021, there are just over 506,000 seniors aged 65 and over living in Nevada. 70% or 354,000 may require some type of long-term care in their lifetime. Approximately 90% of these seniors' income is above the poverty line and will not qualify for financial assistance to help pay for these costs. Presently in Nevada, the monthly median cost of long-term care ranges from $1,800 a month for adult daycare on the low end to $10,300 for nursing home care each month. Many seniors will have to pay for these costs privately, rely on caregiver support from family and friends, which is not always available, or they will have to spend down their assets to qualify for financial assistance, increasing the financial burden placed on the state's budget. There is no easy fix to this problem, but one fact stands out. The costs of long-term care services continue to increase. The members of this forum have the power to help find a solution to this problem. Let's work together and have Nevada be a front runner in identifying a solution to this problem and to request a task force be implemented to target this issue in Nevada. Thank you for your time.
Thank you. Could you state your name again, please? Can you spell the last name?
It's A-R-C-A, D as in David, I, P as in Paul, A, N as in Nancy, E.
Thank you. Is there anyone else in Las Vegas that would like to provide public comment at this time? BPS, is there anyone on the line? If there is, please add the first caller with public comment to the meeting.
The public line is open and working. However, there are no callers at this time.
Thank you. Seeing there are no callers, we will get started with the first agenda item. First item is approval of the minutes for the meeting of April 7, 2022 and May 12th of 2022. Forum members, are there any questions regarding the minutes? Seeing no questions, I will entertain a motion to approve the minutes of the forum meetings of April 7 and May 12th, 2022.
Madam
So
President,
moved.
Second,
Madam President, I so move.
Lucille Aiden, second.
Thank you. Dr. Jordan has made a motion, and Ms. Aiden has made a second. Is there any discussion? All in favor, please say aye.
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 Opposed? Thank you. The motion carries. Agenda item 4 is the presentation on current challenges and opportunities for long-term care in Nevada. Our presenters will be Ms. Marie Cole, Adult Rights Supervisor with the Long-Term Care Ombudsman Program, and Ms. Crystal Wren, Social Services Chief with Community-Based Care Programs for the Aging and Disability Services Division with the Department of Health and Human Services. Questions will be taken from the forum after the conclusion of the presentation. Ms. Coe and Ms. Wren, feel free to start when you are ready.
Good morning, Madam President. For the record, my name is Marie Coe. I am the Interim Long-Term Care Ombudsman. On behalf of 16,613 residents living in long-term care, we would like to thank you for the opportunity to discuss the current challenges and opportunities in long-term care in Nevada. Today, we will be discussing the Long-Term Care Ombudsman Program first, and then move on to community-based care, and wrap up with caregiver support services. We will have an opportunity for questions, and our contact information, as well as acronyms, will also be provided in this presentation. In Las Vegas, one of our supervisors, Erica Billinger, is available and in person, and she will be able to speak with you about the long-term care challenges further.
Good morning, Madam President,
Good morning. You may proceed.
Thank you. I'll start off with the overview of the Long-Term Care Ombudsman Program. We're authorized under the Older Americans Act. Federal law requires each state to have a long-term care ombudsman program. The Long-Term Care Ombudsman Program receives complaints and conducts investigations. We assist residents with concerns related to day-to-day care, health, safety, and personal preferences. We provide information to the community regarding long-term care in Nevada. We provide education to residents, families, facility staff, and others on a variety of issues related to aging, long-term care, and resident rights, and provide in-service training for long-term care professionals regarding trends and best practices to improve the quality of care for residents. In addition to that, we also conduct regular unannounced visits to facilities. Facility types. We have 3 different types of facilities. We have the home for individual residential care, our HERC homes. We have the residential facilities for groups, also referred to as assisted living facilities. Those have Alzheimer endorsements for residential facilities for groups. And with those Alzheimer endorsements, it's mandated that there's 1 staff member for every 6th resident. And then we have our skilled nursing facilities. Any information regarding our facility types can be found under NRS Code 449A, Care and Rights of Patients. And then our long-term care issues. We'll start with discharges from facilities. Our skilled nursing facility concerns are regarding residents who are sent to an acute setting, such as the hospital or behavioral health, are not permitted to return to the facility if there is an undesirable behavior. The resident should be provided a discharge letter with information to contact the Long-Term Care Ombudsman Office as well as file an appeal. Next are the letter of agreements. Group homes have an increase of admissions for residents who transfer from the hospital under a letter of agreement from the hospital. The letter of agreement is a contract between the hospital and the group home provider, which indicated a higher monthly payment for resident care than the resident can afford. When the contract ends, the resident is evicted for non-payment. And then the discharge and eviction rights for long-term care settings that do not fall under the Nursing Home Reform Act. The settings rule for residents on the Medicaid waiver program have protections if they are denied for services. However, they do not have an appeal process if they receive an eviction letter. This is the case for residents in group homes, assisted livings, and HERC home settings. Skilled nursing facility residents fall under the Nursing Home Reform Act. Workforce challenges. There's an ongoing pandemic recovery. The nursing home industry has shed roughly 235,000 jobs since March 2020, according to an analysis of the U.S. Bureau of Labor Statistics data. According to an article from AARP, dangerous working conditions, poor pay and benefits, limited advancement, and burnout are all factors. The National Consumer Voice for Quality Long-Term Care looked at CMS reporting data and found that bed sores, weight loss, depression, and the use of antipsychotic medication all rose during the pandemic. A personal needs allowance. Residents in skilled nursing facilities who receive financial support by Medicaid are entitled to $35 in personal needs allowance to be used for items such as clothing, personal items, and incidentals. With inflation increasing costs of everyday items, $35 must be saved for many months to be able to replace basic clothing for residents. The personal needs allowance rate has not changed since 1991. The Long-Term Care Ombudsman Program is recommending a change for residents who receive a federal benefit rate such as Social Security or disability income to receive 15% of this income as a personal needs allowance and also allow in an annual an annual assessment of the personal needs allowance. Currently, many states have increased the personal allowance as well as implemented an annual assessment. Arizona's allowance is set at 15% of the federal benefit rate and is currently at $126.15. Colorado updates annually and is currently at $93.17. Ombudsman program staffing. The Ombudsman program experienced significant staffing shortages during the hiring freeze implemented during the COVID-19 pandemic. At this time, 19 of the 20 long-term care ombudsman positions are filled. There are 2 vacant positions currently in the program. There has been an increase in facility visits and cases due to the increased number of ombudsmen since May 2nd, 2022. And the 2 open positions with the Ombudsman program are currently in our Elko region and an administrative assistant to provide support to our program. Thank you.
Good morning, thank you. My name is Crystal Wren, and I will be talking about the community-based program. I am the Chief of Community-Based Care with Aging and Disability Services Division, and I will be introducing the programs that are offered through my unit, as well as data demonstrating our current wait list and caseload challenges and various other issues we have seen over the past few years. Community-based care, referred to as CBC, is the operating agency for the Home and Community-Based Services Waiver for the Frail Elderly, referred to as the FE Waiver, and the Home and Community-Based Services Waiver for persons with physical disabilities, referred to as the PD Waiver. Each waiver is administered by the Division of Healthcare, Financing and Policy, also known as Medicaid. Between the 2 agencies, ADSD and the Division of Healthcare Financing and Policy, we collaborate to develop the policy and procedure of these waivers to ensure the most adequate opportunity for services is made available to those most vulnerable within our state. Each waiver has the eligibility requirements set forth in the waiver application, which allows those who meet a nursing facility level of care access to in-home services. Each waiver requires that an individual be at or below 300% of the Social Security income threshold and require at least 1 ongoing waiver need. Additionally, the Frail Elderly Waiver requires an individual be aged 65 or older, and the Physically Disabled Waiver requires that an individual have a documented physical disability by a medical professional. So CBC also administers and operates 3 state-funded programs, including the Community Service Option Program for the Elderly, referred to as COPE, the Personal Assistance Services Program, referred to as PAS, and the Taxi Assistance Program, referred to as TAP. The COPE and PAS programs are very similar to the Frail Elderly and Physically Disabled waivers. For example, the FE waiver requires that an individual be at or above the age of 65, and the PAS program requires that an individual have a documented primary physical disability. However, these programs do allow for a higher income threshold to allow more entrants to the programs that are state funded. We do allow those that are waiting on a waiver wait list access to these programs to benefit from services provided in-home while waiting for a slot to become available for that waiver. And we do also serve individuals.
Excuse me, Ms. Wren?
Yes.
Could I ask you to wait for a few minutes? We're having a difficulty with our getting the presentation up.
Oh, yes.
Our staff is working to try to get the program up on the screen so everyone can see. Just be a few moments. Thank you.
Madam President, we can see it in Carson City now, the presentation. Thank you.
We're still working to get it up here. It'll just be a couple more minutes. Thank you. Thank you so much. Ms. Wren, would you please continue?
Yes, thank you, Madam President. For the record, Crystal Wren, Chief of Community-Based Care with Aging and Disability Services Division. I will continue on slide 14. For those in the audience, we're about halfway through this slide. So as stated previously, the COPE and the PAS programs are state-funded programs intended to serve those either waiting for a waiver slot to open so they can have entrance to that Medicaid-funded program. It's also intended for those that are above the income threshold, or maybe they have too many resources for them to benefit from receiving services in the community. The TAP program, the Taxi Assistance Program, is a service that allows individuals in Clark County the option to purchase discounted taxi coupons to be available for the use within Clark County taxi cab providers. This service is available to those over the age of 60 and also those with a permanent disability. So next we're going to look at our HCBS, which is Home and Community-Based Services, waiver wait list. So on the screen, you will see that there are two different columns with two different colors. So those will be demonstrated throughout the conversation today. So the waiver programs, we are approved a number of slots each year through the legislature. The Nevada Medicaid Office and the Aging and Disability Services Office works with the Office of Data Analytics to provide projections on how many waiver slots would be needed in the following years, taking into consideration population growth and how many individuals are on the current wait lists. These numbers are submitted to legislature by the Office of Data Analytics, and when the budgets are approved, the final slot count is released and we know how many slots we can anticipate filling over the next biennium. As you can see on this chart, this is for fiscal year 22 to date. The Frail Elderly Waiver, which is on the left side of the columns, had 395 individuals on the wait list as of May 2022. The PD waiver on the far right has 139 individuals waiting as of 2022. The orange color signifies those that have waited less than 90 days, and the blue color are those that have waited more than 90 days. We have seen an increase in the waitlist counts over the past few months, mostly based on staff shortages and a decline in service provider options in the community, and I will get into those later in the presentation. So this slide, So this slide shows those that are in a pending status for the frail elderly and physically disabled waivers. So the color, again, the left side is going to be your frail elderly waiver. The right side is going to signify your physically disabled waiver. And the color indicates specific time frames for each waiver. It follows the same format. It is for fiscal year 22 to date. So this has the same number data range that the other slides have. It signifies those that are in a pending status. What that means are these are individuals that have been awarded a wait list slot and we are ready to proceed further. So we have submitted an application to the Division of Welfare and Supportive Services to perform a financial review for eligibility, and we are also waiting for Nevada Medicaid to make a final approval for these individuals. This is all required steps taken within the waiver application to get people eligible for the program. So the reason we have 45 days called out on this slide is the Nevada Medicaid Office has the Division of Welfare and Supportive Services Office has 45 days to process an application. So the 45 days signifies how much time has elapsed since we have received a slot, awarded the slot, and we are waiting for the next steps to be taken. There can be varying reasons why an application would be pending more than 45 days. Commonly, an individual may have a financial trust, or there may be some financial documentation that we are working with the individual and their family to obtain. So this slide covers our COPE and our PAS program wait list. So these are the two state-funded programs that have services very similar to the FE and the PD waiver. It is going to also signify federal fiscal year 22 to date. The left side is going to be the COPE demonstration, and the right side of the slide is our PAS program. We can see, based on this, that the caseload sizes are much smaller. This has been standard over the past several years, just based on the need and based on the entrance within these programs. As of May of 2022, we did have 17 individuals waiting for the COPE program and 6 for the PAS program. Many of these individuals are waiting for similar reasons with the welfare application on the prior slide. We're gathering financial documentation, and perhaps we're working with the physician to gather the medical records needed to determine their physical diagnosis. So the program capacity slide demonstrates how many slots are available for each home and community-based service waiver that CBC oversees, as well as the PAS and the COPE program. I will point out the significant difference in caseload capacity for the FE and PD waivers, which have Medicaid-funded monies associated with them, versus the state-funded COPE and PAS programs. The blue column demonstrates the budgeted caseload size. So the blue is going to be on your left. Each number represents the number of slots available for each program. And the orange is going to be currently where we are at with each program. So you can see, for example, the home and community-based service waiver for the frail elderly, the first 2 columns. We are budgeted at 2,713 slots. We are currently serving 2,530 individuals. So let's talk about the challenges CBC has seen over the past several years. We have faced challenges which are no different than national challenges and challenges within other agencies within the state. Currently, CBC has a 61% vacancy rate within our intake team. This causes delays in processing applicants to get through the process for waiting for a slot or just to move to the next process prior to being eligible for the program they have applied for. Our ongoing case management position has a 26% vacancy rate. The cause and effect of these vacancy rates is seen on the waitlist slides shown previously. Without case managers, we are unable to process all slots allocated to the programs, and in turn, individuals wait longer for services. Additionally, we have 7 vacant support positions, which include administrative support and supervisory roles. Our providers we partner with are facing many of the same challenges relating to staffing concerns. They're struggling to hire caregivers, and many times we find that the administrator of the agency is performing direct services him or herself. Just to make sure that the individuals that they serve are getting what they need, they are on the floor doing the job. Rates have always been a hot topic. They've always been a conversation starter for many of our providers, and definitely something that is consistent that I'm sure you have heard, that we have heard as well. The rates do remain low, which causes a ripple effect on direct care. The rates cover the provider's administrative overhead as well as the wage that is provided to the caregiver. So when we reimburse, for example, $17 an hour, that has to cover the administrative overhead as well as the hourly wage. CBC has witnessed an unsustainable provider landscape. Many providers have reached their peak of services they are able to offer and are not taking on more clients. This presents challenges to our case managers who reach out to providers weekly to staff and see where they are at with their availability of services. And many times we hear from providers that they cannot take anymore. They don't have staff to provide the services, and they don't have the capacity. So our case managers are looking for service providers weekly to see who we can get staffed for various needs in the community. Many times we will see that an individual receives partial service delivery, and that is again due to the capacity. So for example, if they're authorized for 30 hours per week, the provider may only be able to provide 20 hours per week. So the recipient is left deciding which services are are the most need at that time. And then a lot of times we do rely on non-paid caregivers, such as family, friends, neighbors, and other supports that are available in the community. So now I'm going to talk about caregiver support services that are offered through Aging and Disability Services Division. So ADSD can offer respite services to individuals through the CBC programs, but we also specifically fund caregiver support services through subawards to community partners. These subawards include a variety of caregiver support services such as respite, support groups, and education. Education is a broad category that can include services that help family caregivers maintain their caregiver role. Many of these education programs are evidence-based interventions. Respite is funded either as a direct service where a community partner hires respite workers and/or recruits volunteers, or through issuing of vouchers. In state fiscal year 2023, ADSD has awarded a total of $3.2 million for caregiver support services, which is about $700,000 more than what was allocated for fiscal year 2022. The total requested by applicants in the caregiver support category was $4.9 million. The funding for these services mainly comes from Older Americans Act, but funds for Healthy Nevada Independent Living grants and state general funds are also used to support these services. Despite our increase in funding, we are seeing an increased demand for services. It is difficult for us to quantify this demand as our system does not readily identify caregivers and document them. Most documentation across programs is focused on the care of the recipient. There are also growing workforce shortages and increased demand for higher rates and/or higher voucher services. Finally, across many programs, especially public programs such as the waivers, there is a narrow view of what respite is or who can provide this service. One of the largest providers of respite services is personal care agencies. However, respite can be provided to family caregivers in a number of different ways. And with that, we are happy to answer any questions.
Forum members, we are going to open it up for questions. Please remember to raise your hand or let me know if you have a question so that we aren't talking over each other. Yes, Dr. Wong.
Do you have any solutions for staff to increase staffing? It's a huge issue everywhere, and not only for the administrative, but certainly, like you pointed out, the actual caregivers. So that's one of the, I think we need to tackle that problem. But are there any good solutions?
Thank you for the question. With your permission, Madam President, I'd like to answer the question directly.
Yes, go ahead.
Thank you. For the record, this is Crystal Wren with Aging and Disability Services Division. So that is an excellent question related to an increase in staff shortages. So this is a national issue that we are seeing across the board. Many of our caregiver agencies, as stated, are seeing a shortage in who is applying for these services, as well as who is staying with these. As far as the caregiver agencies, I do know that the University of Nevada, Reno is working on some studies to see what kind of increases can be made to sustain provider support. And then within the agency, we are working together to see what kind of solutions we can come up with, such as training for caregivers, respite, which was mentioned earlier, really broadcasting that service to make that available to folks so they don't receive that caregiver burnout. We are also working with Nevada Medicaid and other entities regarding a rate study to see if there are any increases that can be requested, to see if that would help sustain the provider workforce. In regards to the staffing shortages within CBC, we are working with our Human Resources Department and with the Department of Health, Human Resources and Management for advertising these jobs to different universities and different entities to really get the information out that we are looking for licensed individuals for the social worker positions. So we're really trying to work with community partners to advertise these jobs.
Yes, this
Thank
is.
you, Ms. Wren.
Oh,
Any other questions?
yes. Yes, this is Lucille
Who's
Aiden.
speaking?
Lucille Aiden.
All right, Lucille, go ahead.
Yes, I'd like to ask, how do you handle the situation when you have the patients already and they're not able to get the care that they need because of the shortage? How do you handle that? It's a bad situation.
So this is Crystal Wren with Aging and Disability Services Division. For the record, thank you for the question. This is a challenge that we are facing daily, unfortunately. So we do have licensed individuals who do the case management activities. So they are able to reach resources within the community and within our division to see about getting additional services in the home. Many times an individual who is not receiving the amount of care that they need, my example of requiring 30 hours and receiving 20, what we will do is we will increase our contact with that individual to make sure that their health and safety is assured while they're in their home. So we may reach out monthly instead of quarterly, for example, or they have our phone number, they may talk to them weekly. It really depends on an individual basis. But that is something that we have been really struggling with as an agency, and making those weekly contacts to our enrolled provider community to make sure that they have that availability is the first step. So as soon as we find out that there is a provider availability, then we make sure that the individual identified with the highest need receives that service from that provider.
Ms. Laughlin, I see you have your hand up.
Can you hear me? I'm sorry. Oh, yes, there it is. I have two just points of clarification that I wanted to ask about. When you refer to providers, and you talked, I guess this question would be for Ms. Wren, you talked about that some of them are not taking more cases in terms of because of staff shortages and payments. Are you talking about providers in terms of agencies like home health care agencies and hospice support, or individuals, or all of the above, is one question. And then the other point of clarification I wanted was on the waivers that you talked about that the state is providing, and you're allowing people on the waiting list to access the services. So are they paying for that service, or are you assuming they're going to get approved so they're basically accessing it early? I'm just trying to understand that process.
Thank you for the question. Crystal Wren, Aging and Disability Services Division, for the record. I'll start with your first question regarding what a provider is identified as in my unit. So unfortunately, I think we do forget that we have internal state speak, and then there is some language. So a provider, when I say a provider, that is generally going to be your personal care agency. It's going to be any company that is enrolled with Nevada Medicaid or enrolled with Aging and Disability Services Division to provide a service and be reimbursed for said service. So some of our partner units will say community partners, provider agencies. So yes, so that's exactly who that is. For your second question regarding individuals on the wait list for the waivers. So when I say that they can access services while waiting, that would be access through the COPE and PAS program, which are state-funded programs. For example, an individual who is waiting for the Frail Elderly waiver will meet the same requirements as the COPE program due to the income and the age limit and then the physical need. So what we can do while they are waiting for a waiver slot to become available is we can put them on to our COPE program, or for the physically disabled, they can go on the PAS program, and they can access services through state general fund reimbursed services for the same provider community.
Excellent, thank you. So essentially the state and federal funding programs are working together as people are waiting. Thank you for the clarification.
Thank you. Dr. Jordan, you have a question?
I certainly do. For the record, Marilyn Jordan, representing District 11. My question is for Ms. Coe in regards to the personal needs allowance, $35 a month. That hasn't been moved or changed since 1991. Could you share with us what steps have been taken to try and raise that price?
Thank you for the question. For the record, my name is Marie Coe, Interim Long-Term Care Ombudsman. Madam Chair, may I answer the question directly?
Yes, please.
Thank you. My understanding of the personal needs allowance is it has been attempted to increase by the Division of Welfare and Supportive Services in the past. I do not have the information why it was not increased in the past, and I will be looking into that. However, other states around the country have addressed this issue, and as you know, $35 per month is very low for somebody to buy clothing, essential personal items that they may need, and just frankly go out to lunch is not enough for somebody. Their care needs are met in the facility. Their rent is covered by their pay source, whether it be Medicaid or through a private insurance company, but that does not cover their personal needs, which is why we are bringing it up today.
Yes, I thank you very much for that. I mean, in 30 years, we can't do better than $35 a month for personal needs. Just simply, I can think of personal needs that one item could be $25, and there goes your whole monthly allowance. So I do sincerely hope that we address that issue and that you get back to us on next steps for what's going to happen. This is not acceptable for the state of Nevada at all. Thank you.
I agree. Thank you.
Ms. Levitt, you have a question?
Yes, let me check my video.
Yes, I think this question also is regarding the personal needs allowance. So I assume it'd go to Ms. Cole as well. During my social work years, I managed 2 children's programs, the Southern Nevada Children's Home, which was state-sponsored, and then Child Haven, which is the county. And in neither of those programs did we have adequate or money for clothing, personal items, and incidentals. So we heavily depended on donations. Most of the clothing that our children had were donated, and a lot of the donations that we got were new clothing. People were very generous when they know the need. So my question is, I guess, is that something that can be done? I realize that both of my programs were in a location where people were aware of them, and you've got people scattered all over the place. But if there was some place that there could be a donation center, in my experience, when people are aware of the needs, they are very generous. And when they would become aware of this kind of miserly little income that is given to these people, I can see that people would come out in droves to help.
Thank you for the question. And again, for the record, Marie Coe, Interim State Long-Term Care Ombudsman. I am aware of a program. You may have heard of it. It is called Be a Santa to a Senior. It is once a year where people will gift things like clothing, blankets, pillows, things that the personal needs allowance would be spent on throughout the year. However, this is once a year, and donations for individuals who are adults, they would have to constantly submit what they are requesting versus being able to buy it as an independent adult themselves and have the rights to do that. They would have more independence. They are allowed to leave these facilities. However, when they do leave, they have no income to be able to do the things that they like. So not only for clothing and things, but to go and access the community and see a movie, go visit a museum. This income can also provide for items like that, which could not be a donated item. I do agree with you that there needs to be more awareness about the ability to donate to adults in these settings, because there is a need for them to have basic items that the community would rally and be able to help provide for them.
Thank you. Mr. Troth?
Thank you. Back to personal needs allowance on slide 8. That $35, that's, who pays that? Is that Medicaid, federal tax dollars that comes to those programs? And then second part of that question is that the amount that Nevada folks are receiving at this time?
Thank you for the question. For the record, Marie Coe, Interim State Long-Term Care Ombudsman. The $35 comes from the resident's income. So for our example and our recommendation is to allow the resident to keep a greater amount of that income. Many residents in skilled nursing facilities are on institutional Medicaid. And so, as was initially stated by public comment, the amount of cost of care may be $10,000 a month, and a small amount is paid for by the resident through either their Social Security, a pension, a disability income, and that $35 is what they are allowed to keep out of that income. We are asking for, similar to Social Security, which is reviewed every year, and disability as well, for the resident to be able to keep a percentage instead of a stated dollar amount, a percentage of that income, which would be reviewed annually and be a higher amount for them to be able to spend on their needs. So their personal needs allowance would also increase with that review. And similar with other states, they have a 15% allowance that they are providing to the residents to keep, and that amount is much higher. Nevada is one of 3 states that are at this low dollar amount for their residents to keep that income.
Thank you. So it comes from whatever sources, and that could be multiple sources that are providing that. So then that,
correct.
Who can change that percentage? Is that a state of Nevada legislature?
I will have to get back to you on who will actually change the amount. I believe it has to go through Nevada Medicaid, but I will confirm that.
Okay, and Nevada Medicaid's controlled by the state legislature?
Yes.
Okay, just some clarification. And you may not know this answer. So those other amounts, the examples here you got from Arizona and Colorado, those were changed through some kind of legislature action to increase those amounts, to the best of your knowledge?
Yes.
Thank you very much.
Thank you.
Can I, Madam Chairman, can I have some more questions?
One moment, let me see. Does anyone else? Dr. Jordan first, and then we'll go back to you, Mr. Troth.
Thank you very much. As I understand it, each state determines the amount of money. And in terms of Social Security, for example, Social Security increased in 2022 5.3%. And none of this has changed or helped or aided any of our residents. And as a representative for our seniors, we definitely need to address this issue. I can think of a million things that one item would cost more than $35. And this needs to be brought to the state legislature as soon as possible. Are you aware of any bills or anybody that's moving to do something about this?
For the record, Marie Coe, State Long-Term Care Ombudsman, Interim. I am not aware of any other forum that is bringing this as a bill.
Thank you.
Thank you.
Peggy Levitt, I see you have your hand up. Go ahead. So Laura Levitt. I'm sorry. It's Laura Levitt. You have your hand up.
Thank you. Yes. Going back to the provider shortage that was mentioned earlier. This may be coming up in another presentation, but I just wanted to mention that from a few years back, isn't the staff shortage because of how little the actual providers, caregivers that work for the providers are getting paid? That's $10 to $11 an hour. And that there's several pushes to have that increased to $15 an hour.
For the record, Crystal Wren, Aging Disability Services Division. For my knowledge, that is one of the reasons that we have heard throughout is the low reimbursement wage for staff.
And do you know where that is being addressed? Is that in that SB 340?
Crystal Wren, for the record. I'd have to get back to you on that. I don't know if there's a specific area that controls the wage. I know that with the rates for the services rendered through Nevada Medicaid, that is the reimbursement rate that is issued to the agency, and that rate is to control the administrative overhead as well as the hourly wage, but Nevada Medicaid does not control the actual wage that is reimbursed. That is dependent on each agency themselves as an independent party. So anything outside of Nevada Medicaid, I wouldn't be able to answer, but I can do some research and see if I can bring some information back.
Okay, thank you, because $10 to $11 an hour is not something that would mean a long-lasting job, I would think. There's jobs at Panda Express currently for advertising $19 an hour. So just wanted to mention that. Thank you.
Mr. Troth, you had a question?
Sorry. Roger Trotham, District 8. Slide 12 on the CBC programs. Question, for those 3 programs, how often is the criteria reviewed and adjusted for people looking to get into those programs? Any idea?
Crystal Wren, for the record, Aging and Disability Services Division. The criteria is set within the waiver application, which is a document approved by the Centers for Medicare and Medicaid Services. This is reviewed and reapplied for every 5 years. So it has a kind of like a 5-year benchmark. There are some standards that are within the federal requirements for each waiver type, depending on the population you serve. So that some of that does mirror those entrances, such as the level of care. That is a requirement for every waiver within the nation. Every 1915C waiver, I should clarify, to have a nursing facility level of care. The income thresholds can be reviewed by each state if that is something that is of interest. It has not been re-reviewed. It does mirror currently the nursing facility level of income requirements, which is 300% of Social Security income.
Follow up then. So most of this is federal government directed criteria?
Crystal Wren, for the record, I would say it's a good healthy mix. So the federal government has what's called a waiver application. It's kind of like your policy on how to write your waiver application, and it does have certain requirements within it. But the CMS does try to give states leeway to build the program according to the need within the state, which is what these waivers have been built on. That's where the 300% threshold comes in.
Okay, and then which agency in the state of Nevada would have input to that?
So the administrator of the waiver, excuse me, Crystal Wren for the record, the administrator for the home and community-based waivers is the Division of Healthcare Financing and Policy, AKA Medicaid. And then the operating agency is us, the Aging and Disability Services Division. So it's a partnership. However, the DHCFP has the authority to make the final changes and submit to CMS for approval.
Thank you. One more, Madam Chair. Sorry. 19, to slide 19 area, caregiver support services. I'm going to ramble just a couple things here, and then I'd like what you all have some ideas. A lot of the support of the services that are provided are some type of private company. What's the state and you folks' opinion, and I know you have to be careful on some of that, of where the industry is? We've had some comments, and I think we're going to talk about later, pay scales. And we are looking at, this is a lot of money involved in how to do this, and obviously people aren't going to do things for minimum wage and whatever. Does private insurance, does government funds, and the mixture of money available, it doesn't sound like that's being either utilized or not enough to provide level compensation for competent support and help in some of these programs. Do you all look at that, struggle with that? I know you're looking at, you've got workers, case workers can't find services for people. Is insurance companies not always available to do that? Is there regulation that keeps them from being more profitable in doing some of this? And then that's the last comment I'm going to have on this block.
So thank you for the question. Crystal Wren, Aging and Disability Services Division for the record. So many of the services that are offered through Nevada Medicaid for the waiver populations, and then the state funded options that we went over today, are not through private insurance. So many private insurance do not reimburse for personal care related services. Respite generally falls into that. So a lot of these are really dependent on your federally funded monies as well as your state general fund. So there is a connection with these services between the federal funding and the state funded programs to ensure that they are doing what they need to support our vulnerable populations, but the private insurance is not generally a mix into that. I will say that that Medicare recently adopted many of these programs into their reimbursement structure, so that has assisted individuals with gaining access to services, but the access is limited by provider availability, so that continues to be a struggle.
Thank you, Ms. Wren. Ms. Laughlin, I see you have your hand up again. Can you turn your mic on? We can't hear you, Ms. Wren.
What, am I here? Hello?
Yes, now we hear you.
Okay, perfect. This question, Lisa Laughlin for the record, this question is for Ms. Wren. Just one more point of clarification. On the waivers, again, I had the same question about how often they're reviewed, but do you have any statistics on how long, once people are on these programs, and obviously they may differ because some are frail and elderly and some have some special needs, how long are people generally on the programs? Are they on and off, or once they're on, are they generally on for 5-10 years?
Thank you for that question, Crystal Wren, Aging and Disability Services Division for the record. We do have data. I do not have it today. I can get that and provide that to to the committee. I will say that we do see a lot of individuals, once they are approved for a waiver and they are generally on until they're into the next stage, either in a nursing facility or unfortunately they pass away. So it's usually a long-term assistance that we do provide. We do have some individuals on our physically disabled waiver that have been on for longer than 10 years. Our systems go back, I believe 2006. I'll have to get that for you, but we have individuals that were on before that we got the new system. So we have some long-term individuals on our systems. Most of the frail elderly, by nature, is going to be a shorter duration that they are on the services. Again, either they go into a long-term service area, or perhaps they move out of state, or they're no longer with us. So we do see that is not as long, but I will definitely get some information back.
Thank you.
Thank you. I have a question for you, Ms. Wren. On page 12, where you talk about the taxi assistance program, in Clark County, the RTC has a bus program to help seniors and physically disabled. It's like $3 each way, and sometimes that $6 is a lot of money for someone disabled. I wonder if that is included in this taxi program?
Thank you for the question, Crystal Wren, Aging and Disability Services Division, for the record. The taxi assistance program is funds received through the Taxi Cab Authority, and it is only for taxi cab services. So the RTC would be excluded.
Thank you. And I have one more question. On this, again, this personal needs allowance, can you give us possibly what an average amount of funds a person might need per month, so that if we, decide to ask our legislature to do something about this, we might have a number in mind?
For the record, Marie Coe, Interim State Long-Term Care Ombudsman. As far as an average of what a person might need, it is up to the individual and their spending habits. So someone might not have a haircut every single month, where other people might have a haircut every month. What I might be able to do is give you an average of what all the other states are also doing. And so we can have an average number of the personal needs allowance. I can collect all that data. I can also have our ombudsmen who are going out into the field do some surveillance and talk to the residents directly about the personal needs allowance and gather that data and bring it back to you.
Madam Chair, I would suggest we ask to do that. That would give us data and information.
Thank you, Mr. Troth. Also, I'm wondering, as you're gathering that data, maybe you could give us some sort of a list of what these personal items, that are not provided, where they are residing, that they might need, what are they spending this $35 on? That would be very helpful.
For the record, Marie Coe, Interim Long-Term Care Ombudsman. I can provide that list to you.
Thank you so much. Any other questions, Dr. Wand?
I have a question for the seniors that are already in long-term care facilities or nursing homes and so forth, and they're paying for them, but on their own funds and so forth. If they run out of money, what happens to those people?
For the record, Marie Coe, Interim Long-Term Care Ombudsman. People who are in skilled nursing facilities, if their income continues to be spent, so if the person had a house that was sold and that money is now being spent towards their care, if all of that money is spent down and then their monthly income qualifies for institutional Medicaid, then the facility would assist them to apply for institutional Medicaid, and they would still be entitled to have a personal needs allowance based on their ongoing income. So typically somebody who is retired has Social Security, maybe a pension from an employer. It's not a lot, and it doesn't cover the amount of cost for skilled nursing facilities. And so all of that income goes to the nursing home for their care, and at the moment, they are only allowed to keep this $35 per month.
Thank you. Seeing no other questions, thank you very much for this presentation. I think this personal needs allowance has struck a nerve with some of us that we would probably like to further look at that and possibly what can be done. Again, thank you so much for your presentation. I appreciate you being here.
Thank you.
Thank you.
We're moving on now to Agenda Item 5, an overview of Senate Bill 340, which establishes a Home Care Employment Standards Board to investigate and develop recommendations regarding certain matters related to the wages and working conditions of home care employees. We will now have Ms. Kayla Samuels and Ms. Terry Henwood of the Division of Public and Behavioral Health present an overview of Senate Bill 340 from the 2021 legislative session with information about the Home Care Employment Standards Board. We will take questions from members at the end of the presentation. Ms. Samuels and Ms. Henwood, feel free to begin.
Thank you. For the record, my name is Kayla Samuels. I'm a management analyst with the Division of Public and Behavioral Health. Originally, my co-presenter was supposed to be Cody Finney, Deputy Administrator for the Division and Chair of the Home Care Employment Standards Board. Unfortunately, she was unable to join us today, so Terry Henwood has kindly stepped in. So we will be going over the Home Care Employment Standards Board. And on the agenda, we're going over Senate Bill 340, including its origin and what it specifies as far as members and the purpose of a Home Care Employment Standards Board. We'll then be going over the Home Care Employment Standards Board progress so far, including recommendations to Director Richard Whitley and our next topics of focus. After that, we will be reviewing oversight of personal care agencies performed by the Healthcare Quality and Compliance section, including powers and duties of HCQC, common sanctions, and the penalty process. So with Senate Bill 340, it was created in 2021 by the 81st legislative session, which authorizes the Director of the Nevada Department of Health and Human Services, DHHS, to establish a Home Care Employment Standards Board for the purpose of reviewing, investigation of, and making recommendations for the improvement of working conditions in the critical home care industry. On June 9th, 2021, Governor Sisolak signed SB 340 into law, and thereafter, DHHS Director Richard Whitley authorized the creation of the Home Care Employment Standards Board, HCESB. Per the bill, members include the director or his or her designee who serves as chair and a non-voting member. Currently, that is Cody Finney, Deputy Administrator of the Division of Public and Behavioral Health. The board also includes the following voting members: the Labor Commissioner, 3 representatives of home care employers appointed by the director, 3 representatives of home care employees appointed by the director, and 3 persons who receive or are representatives of persons who receive services from the home care employee appointed by the director. According to SB 340, the HCESB shall conduct an investigation into matters relating to the wages and working conditions of home care employees in Nevada and the compliance of home care employers. They are also tasked with developing recommendations regarding the minimum wage that may be paid to a home care employee in Nevada, or the safe and healthful working conditions for home care employees. It also specifies that no later than 1 year after the first meeting, the HCESB shall submit its findings and recommendations to the director, and that report is due this December. The next couple slides will be going over the scope of investigation tasked to the board, which include the adequacy of wage rates and other compensation policies of home care employers to ensure the provision of quality services and sufficient levels of recruitment and retention of home care employees, the sufficiency of levels of recruitment and retention of home care employees, the adequacy of the role of home care employees in making decisions affecting their wages and working conditions, the adequacy and enforcement of training requirements for home care employees, the impact of home care programs, the larger system for long-term care in Nevada, and any efforts to reach the goal of rebalancing long-term care services toward home and community-based services on the wages and working conditions of home care employees. The impact of systemic racism and economic injustice on home care employees, and the adequacy of efforts to alleviate such impact through the development of career paths through partnerships between labor management and other methods, and the adequacy of payment practices and policies of the state as such practices and policies relate to the reimbursement of home care employers for the provision of services under the home care program. Next, we'll be going over the progress that the board has made thus far. So far, the board has made a recommendation that the Nevada Administrative Code, NAC 449.3973, detailing the duties and responsibilities of administrator, be updated so that required trainings must be paid for by employers. In addition to that recommendation, recommendations regarding the Medicaid Home and Community-Based Services Plan have been made, including that DHHS reopen the deadline for employers to apply for the first round of $500 supplemental payments, that a notice is sent to employers stating that they are expected to apply for the $500 supplemental payments for employees, and to make it mandatory for employers to apply for the future rounds of $500 supplemental payments to employees, and finally to require that Nevada Medicaid obtain reports from personal care agencies receiving the 15% supplemental payment on how they are spending that additional funding. In the near future, the board plans to address adjustments to the rates for Medicaid waivers and personal care worker wages, as well as evaluate a survey for personal care employers and employees that has been distributed to gather evidence to inform future recommendations. The goal of this board is to develop recommendations relating to all areas in the established scope of investigation that was addressed earlier. And then I will turn it over to Terry Henwood for the rest of the presentation.
Good morning, Madam President. Good morning, committee members and meeting members. I'm here today and I want to discuss the last portion of the presentation with you. My name is Terry Henwood. I am a supervisor with the Division of Public and Behavioral Health, Healthcare Quality and Compliance. We're responsible for licensing facilities and then going in and inspecting facilities and ensuring a compliance with the regulations. Today, I'm just going to be talking to you about our powers and duties based on the NRS, and I'll be going over those two oversights with you. The first of our powers and duties of healthcare quality and compliance is the NRS 449.0307, which states upon receipt of an application for a license, healthcare quality and compliance may conduct an investigation into the premises, facilities, qualifications of the personnel, methods of operation, the policies and purpose of any person proposing to engage in the operation of a personal care agency. I'd like to discuss the process a little bit with all of you, a kind of a lifespan, if you will, of an application on what an application goes through in order to get to our department. First and foremost, if a personal care agency would like to operate, they submit an application that's where NRS 449.0307 kicks in. And that application comes through our licensing department. And our licensing department has their own procedure, but basically it is to review the application and make sure that the application meets all of the requirements for the licensing department's standards. So once it fulfills those responsibilities, our department, our regulatory department, gets a notification of that application and that it's ready. And once it's ready, it will be assigned to a surveyor who then goes out to inspect the premises, facilities, qualifications of personnel, the methods of operation, policies, which are described in the slide there. So I did want to kind of go over, because sometimes it just gives the authority and it doesn't describe the actual process. And that is our process. And we try to do that as quickly as we possibly can, because we do know that personal care agencies are ready to be licensed and ready to provide care to clients. The second power and duty of healthcare quality and compliance I'd like to review with you today is the complaint process. NRS 449.0307 also states that upon receipt of a complaint against a personal care agency, healthcare quality and compliance may conduct an investigation into the premises, the facilities, qualifications of those personnel, methods of their operation, policies and procedures, and records of the facility or any other facility which might have information pertinent to that particular complaint. And just like I went over the lifespan of an application, I would like to go over the lifespan of a complaint as well. And once a complaint is made to our department, that complaint goes through a variety of channels. First and foremost, it goes through our complaint department channel, who reviews the complaint and then assigns it to actually myself or another supervisor. At that point, we receive it, we review it to see that the allegations that are made are categorized appropriately for investigation. We prioritize this complaint from anywhere from 3 to 45 days based on severity of the complaint allegations. And then we schedule it for a surveyor to go out and investigate the premises, which NRS states. I'd like to move on to the next slide, which states common sanctions applied by our department to personal care agencies. And I'd like to say before I go over this, that our department is very invested in working with the providers or the licensees. And we want to work with them before we get to a sanction type of a place. So one of the things that we do work with the facilities on is trying to come into compliance, but sometimes that isn't, it doesn't work that way. And sometimes the agencies, they don't come into compliance. And so therefore sanctions are required. Sanctions can be imposed for a number of reasons. I wanted to provide some examples of why a sanction would be on the table. One is if we go out on a complaint and we substantiate that complaint for some type of egregious reason, such as abuse or neglect. If there are high severity levels of citations, so if our inspectors go out onto the premises and find that there is deficient practice, it's not just the deficient practice, but the severity of that practice and how many people are affected. Repeated offenses, and of course, like I said, just abuse and neglect. So those are some potential examples or reasons for sanctions. Before we get into denial, suspension, or revocation of a facility, we try to go more of a least restrictive route. And so some of those options there, which include the directed plan of correction, a ban on admissions, a monetary penalty, those may be imposed as a lesser restrictive option before denying, suspending, or revoking a license. That is really a last resort. Have we had to do it? Yes, we have. But we do try to bring the facility into compliance by asking them to either have a directed plan of corrections that will address the problem, pose a ban on their admissions, or possibly dole out a monetary penalty. But even before those sanctions, we do try to work with the facility. And if we could move on to the next slide, this will be the final slide. I'd like to discuss one more process with you that many of you may have heard of or experienced, is the unlicensed facility process. And for many of our providers that are licensed, this is a very frustrating experience when there are unlicensed facilities out there. We do have a process for this. And before we believe that an agency is operating a facility without a license, we usually get a tip-off or a complaint, if you will, and which states that there's an address and they may believe that an unlicensed facility is operating. An unlicensed facility would be a facility that's providing some kind of care, including medication management, hygiene, assistance with daily living skills. Care has to be being provided in that home. So once we have that, a complaint or referral, we issue an order. We actually assign it to our investigators, and our investigators go out, they review and inspect the premises. And if they find that indeed this is an unlicensed facility, in order to cease and desist the operation of that facility is provided at that time. The order is served by personal delivery, as the inspectors are on site, or by certified or registered mail. The order is effective upon that service. At that point, the agency could choose to cease operation and the penalty process would end right there. But the agency could also apply for a license within 30 days and the penalty process would also end there. So they do have a couple of options once provided that cease and desist notice. The agency, if the agency does not voluntarily cease operating the facility or apply for licensure within the 30 days after the date of the service of the order, then HCQC would bring an action in a court to address that agency. So there's a process that does go on. It is a swift process. However, it is really up to the agency to make a determination on which avenue they're going to go. If unfortunately an action has to be brought in court, our department, Healthcare Quality and Compliance, will show the court that the agency is operating without a license. So we would provide our evidence in the form of observation and interviews and record reviews. If there are record reviews, we would present that. And then the court may urge the agency against operating the facility or potentially impose a civil penalty on the operator to be recovered by Healthcare Quality and Compliance of no more than $10,000 for the first offense. $10,000. So that is I just wanted to point out that that is potentially what could happen. Of course, just like sanctions, and our department likes to work with providers out there to not get to that point. But if it does get to that point, the final the final step in the process is that healthcare quality and compliance deposits the civil penalty into a separate account in the state general fund to be used to administer provisions of the NRS 449.001 through 449.430. And these NRSs have oversight for protection of the health, safety, well-being, and property of patients and residents of the facility. That would conclude the presentation for healthcare quality and compliance. We do have a question and answer period on the next slide.
We do. Kayla Samuels for the record. Thank you, Terry, so much. We'll now take some questions from anyone who has them, and I will put the contact information for both Cody and myself up in a moment as well.
Forum members, do you have any questions? Dr. Marchant?
Thank you, Madam Chairwoman. Go please to the last slide where if the agency applies for a license within 30 days, the penalty process ends. Does that mean at that point it goes back to the investigation of the application and the process starts over?
For the record, it's Terry Henwood. Madam President, can I answer the question directly?
Yes, please.
Thank you. Yes, so once, I hope I'm answering your question correctly, but once they decide and make a determination that they will go ahead and follow through with the application process, and they have the 30 days, they will go through the licensing unit of our department and submit the application, and we would be monitoring this facility the entire way.
So have you ever had a facility apply within 30 days and not be ultimately licensed?
Not to my knowledge. Again, for the record, Terry Henwood, not to my knowledge. Those facilities that apply to be licensed, who make that effort, our department sees that as a show of good faith, and we do attempt to work with them. Now, that's not to say that it may take a little bit longer because they don't have they are not qualified per se in our regulatory standards, but we do attempt to work with those facilities. And not to my knowledge, sir, have we had someone apply for licensure and be denied.
Is to get them open and not close them unnecessarily.
Correct.
Thank you.
Laura Levitt, you have your hand up. Go ahead.
Yes, thank you. On the creation of this board from SB 340, I know that on one of the slides it indicates that they would conduct an investigation into matters relating to the wages and working conditions of the home care employees in Nevada, and develop recommendations regarding the minimum wage. And then it indicates further down that they're also looking at the sufficiency of recruitment and retention, and that this may not go to the director, Richard Whitley, until December. Will that be in time for them to make recommendations for the next legislature? Or do you know if that's just that they may come back with something sooner and that's just what's written in the law? Because it's at a crisis state now with providers and caregivers, from what my understanding is.
Madam President, may I answer the question directly?
Yes, please.
Kayla Samuels for the record. Thank you for your question. As it currently stands, when the board makes a recommendation to the director, that recommendation is passed on to the director and his team as soon as possible. It does not necessarily wait until the report at the end of December. That report will be just a culmination of the findings. However, the recommendations made do carry on immediately, and then after it is approved or denied from the director, it is then carried on through the available avenues by the state to be enacted, or at least start that process.
Okay, thank you.
Ms. Laughlin, you have your hand up. Go ahead.
Yes, thank you, Lisa Laughlin, for the record. My questions are also about SB 340. I'll piggyback a little bit with the last question about the recommendation for increased minimum wage. And I'm thinking back, which I don't disagree with, because it's a skill. We need to pay these people, but I'm trying to figure out the whole circle in terms of money, because there's also a reference to low reimbursement for providers. So it seems like, we have a funding circle problem. So I wanted some insight on that and how we're trying to work through that. And then also on slide 9, there were the 3 points about $500 supplemental payments that facilities are, I guess, required to or expected to ask for that money. But then there was also a reference to the employers paying for the training. So I guess my question is for additional training and education, which is great, but does that supplemental funding pay for that education, or are those two separate? I'm not sure how that all goes together, I guess.
Kayla Samuels for the record, and Terry, please feel free to jump in if you have more concrete information. So I'll kind of just tackle your questions in the different parts, if that's all right. For the increased minimum wage as well as the rates, the board is actually planned to address that at the next meeting, which is next Tuesday, the 28th at 2 p.m. over Zoom. Anyone interested in attending that meeting, it's open to the public. I encourage you to do so if you're interested. So they are addressing both the recommended minimum wage as well as a recommendation for increasing the rates from Medicaid. As far as the $500 supplemental payments, that was from the Medicaid Home and Community-Based Services Plan, and that is, and as well as the 15% supplemental payment to the providers is separate from the retraining requirement. The training requirement is an NAC, and so the recommendation was to change that statute to reflect that employers are expected to pay for all required training.
Hello, it's Terry Henwood again for the record, HCQC Supervisor. Kayla, yes, she said it perfectly. That is correct. And I would also just like to piggyback that she did mention at the end there that we are working on regulatory language to address the recommendation that the provider pay for the training. So we are in the process of that as well.
Thank you for that. Mr. Silvercross, you have a question?
Fred Silvercross for the record. Under your slide, powers and duties of HCQC, upon the receipt of a complaint, if the complaint is made either by a resident, family member, friend, is there confidentiality so that there isn't any repercussion?
Terry Henwood, HCQC Supervisor for the record. I thank you for your question. It's a very good question, and it's something we take very seriously, 100% confidentiality. We do get this concern a lot when we do get call-ins. It's a very real concern because, as you had mentioned, if it is a resident, a client of an agency, a family member of a client, they are very concerned about that. And concerned about the welfare of their loved one or concerned about themselves, because if they are in the facility at the moment and really do want to make a complaint about conditions of that facility, there is a real concern. So one of the things that our department takes into consideration when we go out is that confidentiality. We do get questions at the facility about who made the complaint. It's a very frequent question from providers. I understand that side too, that we are bound to keep all complaints confidential 100%.
Thank you very much.
Yes, Mr. Troth, you have a question?
Roger Trott, District 18. On slide 12 again, under powers and duties, there's some discussion there about training and the standards. I'm assuming that the state's providing the standards, and is that in the NRS? And then what is the training requirement? Who's directing, who provides, who created that curriculum for the training for these type of positions and workers?
Terry Henwood for the record again. Thank you for your question. I'll try to answer that as concisely as possible. Our regulatory requirements, we have a variety of Nevada Administrative Code regulations that address training. There are several trainings that our attendants undergo. There's training at the beginning of hire that is housed in one NAC. There are regulations for annual trainings, TB testing, physical examinations, CPR. So there are quite a few regulatory requirements regarding training. These trainings at the time of hire include several different personal care topic areas, if you will, related to providing bowel and bladder care, to providing hygiene care. And there's also regulations that prohibit certain services so that everyone's aware, okay, these are the services that I can provide that are a non-medical nature, and these are the services that I am not allowed to provide, such as insulin injection, such as medication administration. So there's several of those NACs, and I would like to ask if it is something that the committee would like maybe a list of the different Nevada Administrative Code sections. I could provide that to the committee via email, but there are several, and it's a good question.
Answer my question. Those are in statutes and regulations. So then let me ask, as a potential worker in this community, is there trainings in the program, our high schools and college programs and other private people training future employees in those fields that helps with that?
Again, Terry Henwood for the record. Very good question. These trainings can be provided by the provider themselves. We do not have a regulation that states where they need to have these trainings. We just state in the regulations what topic areas need to be covered and how to document that. There are several avenues that providers take. They can take these trainings online. They can, like I said, have it in-house, or they can go out to other entities in person to obtain the training, as long as it's in the training area that is deemed by the regulation. Unfortunately, healthcare quality and compliance does not endorse any one training area, but our providers usually will take example from their counterparts and find that training. We haven't had too many problems with that.
Thank you. One follow-up, one last one here. In the licensing process, is this a state only for healthcare, this type of healthcare that we're talking about? Is the state the only ones that do this, or are there any other, do any of the counties or cities get involved in their licensing, of these type of facilities? Because they are in a lot of the, municipalities and counties, and they're all licensing all kinds of different, businesses, and this is a business. What is that relationship in the process of this type of healthcare that we're talking about?
Thank you for your question, Terry Henwood, again for the record. No, this is just the personal care agencies are a healthcare facility that are licensed solely by the state.
Are there any other questions for members? Ms. Laughlin, you have your hand up?
Yes, thank you. I'm just curious if SB 340 or these regulations, do they affect private people who are, perhaps caring for their parents in their home? We're mostly talking, it sounds to me, like providers and agencies, but I'm just curious if they intentionally or unintentionally get wound up in these anywhere.
Kayla Samuels for the record. Thank you for your question. So from my understanding of what has happened within the board, private care workers and private care agencies in general as well, they tend to have after effects from any government or Medicaid changes that occur. So it tends to have a trickle down effect with that. So as far as the board activities, it is focused on private care providers and their working conditions. So if someone is getting a Medicaid reimbursement, whether they're affiliated with an agency or not, then that is where it affects them.
So essentially it ties to funding. If they are getting paid through the state, Medicare, Medicaid, whatever, then they're required to be compliant with everything we're talking about. If I move down to Las Vegas and take care of my father for 3 months on my own time, that's a different scenario.
Kayla Samuels for the record, and Terry, you can jump in. To my understanding, yes, if you're receiving any kind of reimbursement or payment from Medicaid or the government, then this all applies.
And Terry Henwood, for the record, I would agree with that.
I do have a question for you. At the community college here, it's not community college anymore, it's called something else now, but they have a class there where you can become a CNA. Is that the type of worker that is in home health care? I know they do work in the hospitals, they work in doctor's offices, they're not really a nurse, but they're trained in care. Is that the kind of skilled person that you're talking about?
Kayla Samuels for the record. SB 340 specifically addresses home care, not home health care. They are two separate things. Under SB 340, home care encompasses personal care, attendant care, homemaker, companion, respite, and chore services. So those CNA classes would not apply.
I have a question.
So I have a follow-up on that. I'm confused. Are they non-skilled workers? They have no training? They just decide they want to help someone in their home? I'm not sure.
Kayla Samuels for the record. So home care and those who work in home care under personal care agencies, they are required to have a certain amount of training specified in NRS and NAC. So the differentiating factor from my understanding is that those home health workers, they're trained in a more medical field where they do things such as administer certain medications or other things that you would find in a hospital, where home care workers, they are more the, like I said, personal care, attendant care, chore services, where they're coming in, they're helping with everyday services such as cooking, cleaning, toileting, things of that nature.
I have a question.
Ms. Tyler, you have a question?
Lucille.
Yeah. Thank you. I think you're mentioning like a home health aide, and that is something that can be covered by Medicare if you have a licensed person that's in the house. My question is the state involved in helping different agencies or different companies that they're contracting with, that they're funding? Are they involved in helping them to recruit the appropriate people? I do know that it does, in many cases, require licensed people, but there are so many other support staff that can be involved that does not require a license. Are there programs to recruit or to encourage, say, home health aid, caregivers and things of that nature available? How is the state involved? And I'm still not sure of who is funding what. How much is this is federal government, and how much is the state actually involved?
Hi, it's Terry Henwood for the record, HCQC Supervisor. As far as recruitment for healthcare quality and compliance, we don't have currently any programs that help facilities to recruit employees or trained employees. The regulations just require, as I had discussed earlier, the variety of different areas in what non-medical topic areas are required for attendants who would like to go into this field. And again, this training can be provided to the attendant in-house, or if they have had other training out in the community, that can be considered as acceptable. But to piggyback again off of your question, we don't currently have any recruitment programs per se, but I do believe that the Home Care Employment Standards Board is in the process of reviewing those issues. And I don't know where that avenue will take our board, but it is definitely something we can bring up at our board.
Kayla Samuels for the record, just to add on to that. In the scope of investigation for the Home Care Employment Standards Board under SB 340, one of those is the sufficiency of levels of recruitment and retention of home care employees. So that definitely is on the docket for the board to address, and one of the tools we are using to address that is the survey that has gone out to both home care employers and employees. So we hope to address that soon, but at this moment there is not a recommendation.
Ms. Tyler, you had a follow-up, and then Ms. Aiden, you will be next.
I'm sorry. Well, how does the state determine that the funds that they are being given, that it's being given to different agencies and different companies of that nature, is effective, that is actually making the difference? How are they monitoring the care that is being given or lack of care that is being given? And how do they correct that if they are not monitoring it, if they leave it up to the individual companies to make the rules?
Hi, Terry Henwood for the record, Supervisor for Healthcare Quality and Compliance. We are monitoring in, I can only speak to Healthcare Quality and Compliance Regulatory Division. We are monitoring those facilities right now on a periodicity rate of every 6 years. That has changed over time, where there used to be a periodicity rate of every 18 months for personal care agencies to ensure that everyone is trained and the clients within the programs are receiving the care that they agreed to and that the provider agreed to provide. So I can only address the monitoring on our end, on a regulatory end, which is at every 6 years right now for personal care agencies.
Thank you. Ms. Aden, go ahead.
Yes, I just had a comment about a healthcare facility. It's a private healthcare facility called Little Angels. It's run by husband and wife, and I receive a complaint about them. They're not getting nutritious meals and the care they need. So I was wondering now, when it's a husband and wife run facility, they have 3 patients in the house. How is that monitored?
Again, Terry Henwood for the record. Thank you for your question. We are monitoring at a periodicity of every 6 years. If there is a complaint that is presented, then we go out more frequently when that complaint comes in. Our website has a complaint, if you will, documentation area where the public can go and make a complaint online, and it comes directly to our complaint department. But the only way that we would know that there is an issue at a facility would be if the resident themselves or the family member or a concerned community member would contact our office to make the complaint, make the concern, and then we would turn that into an investigation and go out at the facility. That could happen not just every 6 years. Every 6 years is a full inspection of the facility. We could have just been out at a facility yesterday and a complaint may come in today for the exact same facility, and we will go out on that complaint. So it doesn't, we're not bound on when we have to go out. We just need to have the information from the community in order to be able to do our jobs.
Thank you.
Thank you so much. Any other questions from the board? Yes, Dr. Marshall.
A question about training. I'm coming out of my professor bag at this point. When one of the healthcare workers goes through the various prescribed training procedures, is there an examination at the end of it, or do we just get a piece of paper that says we've sat through the thing in a classroom? It's a little difficult for me, for example, to see that somebody could learn CPR by watching it online.
Terry Henwood, again for the record, thank you so much for your question, doctor. It's a wonderful question. I literally had it up on my computer today, but there is a competency exam that not only are our attendants supposed to be trained in certain specific areas, it's not just the certificate that we inspect for. Once that the training is complete, we would want to see that the attendant is competent in that area. And the facilities have a variety of different ways that they can show that an attendant is competent in a specific area. Some do a post-exam, some do an in-person demonstration. Fortunately, our regulations do not designate what type of competency has to be completed, but just some type of competency. And what we see a lot of is the post-exam and the in-person demonstration. So if, as Kayla mentioned, if there is training in preparing meals, then they would want to demonstrate that back to show that they can do that task. As far as CPR should be you had mentioned CPR, so I wanted to address it for you. CPR has to be taken in person and through the National Red Cross. So first aid can be online, but not the in-person cardiopulmonary resuscitation. That has to be done in person.
I am reassured. Thank you.
Thank you. Any other questions? I do have one. Are there background checks done on the facility and on the workers? And kind of a second part of that, because I sat through many of these hearings for that bill, protection for the workers, because in the hearings for that bill, many of the workers were subject to abuse, physical abuse.
Terry Henwood for the record, HCQC Supervisor. I'd like to tackle your first question, and then I'll hand it over to Kayla. The first question, I believe, was about background checks. And yes, Madam President, they do go through, there is a Nevada revised statute that not just for personal care agencies, but also for assisted living facilities, which we also license, for skilled nursing facilities, which we also license. There is a background check requirement law and a criminal history statement that not only fingerprinting, but a criminal history statement that acknowledges that any employee has not been convicted of a laundry list of crimes is completed at the time of hire before they are providing services to clients, and then therefore every 5 years.
Kayla Samuels for the record. Madam Chair, may I ask for clarification on your second question regarding the protection for the workers?
Is there any kind, is the board addressing anything to provide protection for these workers when they go, usually alone, into a home, to provide services? I know in the hotel industry now they are providing some sort of a panic button, for the housekeepers if they, walk into a room and someone attacks them. Is there anything being thought about or discussed in your board meetings to provide any kind of protection, for the workers? Because like I said, in those hearings, there were some horror stories about how some of these workers had been attacked.
Kayla Samuels for the record. Thank you so much for the clarification. Though to my knowledge, it has not directly been brought up in the board thus far, and I came into this position a little late in the process around April. One of the scopes of investigation is the adequacy of the role home care employees have in making decisions affecting things such as their working conditions. So when we do address that topic, I am more than happy to bring that up to the board for their consideration. Thank you.
So much. Laura Levitt, you have another question?
Yes, I just wanted to make sure I understood right, that you indicated that monitoring went from 18 months to 6 years. Is that correct?
Hi, Terry Henwood for the record, HCQC Supervisor. Yes, that is correct. Once upon a time, our periodicity was 18 months, and it was put into legislation. Our periodicity is now 6 years. Again, that was before my time as well. I apologize that I don't have, that I'm not being much of a historian here, but that is the course as I know it. And currently we are inspecting personal care agencies every 6 years.
Can I ask a follow-up? So you don't know the background on that? Because I would wonder why it would go from 18 months to 6 years, that's more than double. That's what, triple?
I would be happy to look into it and provide clarification, if that would be acceptable.
Sure. Thank you.
Anything else? Seeing no other questions, thank you, Ms. Samuels and Ms. Henwood, for a very enlightening presentation. We look forward to the follow-up that you're going to do with some of the foreign members. Thank you so much.
Thank you.
And forum members, before we continue, we're going to take a short break. If you could please be back by 20 after, we'll proceed. Thank you. We're in recess. 4 members, if we could all take our seats, we'll get started again, please. Forum members, we call back in session. So we have agenda item 6, presentation on Alzheimer's patients and services in Nevada, my goodness. Now we'll receive a presentation from Mr. Charles Duarte, the Nevada Director of Public Policy and Advocacy from the Alzheimer's Association. He will give a presentation on the status of Alzheimer's patients and services in Nevada. Mr. Duarte, please proceed when you are ready.
Thanks a lot, Madam President, and good afternoon, forum members. For the record, my name is Charles Duarte. I'm the Public Policy and Advocacy Director in Nevada for the Alzheimer's Association. By way of background, I've been working in healthcare for about 35 years, including 15 years running Medicaid programs, including the Nevada Medicaid program. I spent 12 years as the administrator for Nevada Medicaid and 3 years as the administrator for Hawaii Medicaid. So may be able to address some of the questions you previously asked of some of the presenters. And I think that those presentations were a really good setup for what I'm about to tell you today. But in my current capacity, I also serve as the vice chair of the Nevada Task Force on Alzheimer's Disease and as the chair of the legislative subcommittee of the Commission on Aging. And so it's a pleasure being here today. Madam President, with your permission, can I address a couple of issues that came up in the prior presentations that may help your members?
Yes, please.
So thank you, Madam President. So there was a question regarding the personal needs allowance and who pays that. Actually, that is paid by Medicaid. So if there is going to be an increase in the personal needs allowance, it will be a cost to the state and to the counties. Now, that being said, it doesn't mean it shouldn't go up. It should go up. It just means that there'll have to be an investment. The Commission on Aging heard from experts in the Division of Welfare and Supportive Services, as well as Nevada Medicaid, about the increase in personal needs allowance for nursing facility residents. And so there is a cost. They did present an estimate of that cost. And so hopefully this will move forward. It is one of the recommendations by the legislative subcommittee to increase the personal needs allowance to something around $50 to $60 a month. With regard to personal care services, there are quite a few questions about rates and who pays and how that money gets to employees. I might point the forum to a terrific study that was done by the Gwynn Center in Las Vegas. They're a think tank in Las Vegas, a nonpartisan think tank, and they produced a report in 2020 called Helping Hands, an assessment of personal care services in Nevada. And essentially what they pointed to are the problems that you folks have touched on. And that is low wages, the fact that personal care aides themselves are disproportionately women of color, and their average wage is around $11 an hour. And one of the things that was pointed out is that in order for those wages to go up, the Nevada Medicaid program, and hence the state and federal government, would have to pay reimbursement rates more. Because there are really two sources of payment and only two payers that pay for personal services in the home, Medicaid and out-of-pocket. And so Medicaid is the biggest payer, and so they would have to increase their payments to these agencies so that it could hopefully filter down to those employees' increased wages. There was a reference to a $500 supplemental payment that the state was making. That is a part of the American Recovery Act. And it's a one-time payment. It's not going to be any future payment. And so if rates are going to be going up on the Medicaid side, it has to be a part of the governor's budget and the legislative budget, and it could be a significant cost. But again, it's one of those investments that we're going to have to make. And one of the things I'll touch on today is this care gap that you folks have been talking about. There are 13,000 personal care attendants in Nevada. By 2050, we're going to need 10,000 more, but experts are saying that that number of 13,000 is not going to increase. And so there's a significant care gap that is going to have to be addressed. And those will have to be addressed through working conditions and wages. So again, it's a serious concern. Training is also a concern for the Alzheimer's Association. We really want a dementia-capable workforce. And right now, there is really no training requirement for in-home care providers around dementia services and how to communicate with somebody with dementia and how to deal with someone with dementia. So again, that's another one of our priorities. But with that, I'm going to head into my presentation. So I'm going to be sharing my screen.
Thank you so much for that information.
I'll see that. Can you all see that?
Yes, we do have it on our screen. Thank you.
Very good. Thank you very much. So again, my name is Charles Duarte, Chuck Duarte, the Nevada Public Policy and Advocacy Director for the Alzheimer's Association in Nevada. And it doesn't look like my slide wants to progress. There we go. Okay. So a few things I want to talk about today. I want to talk about some facts and figures on a national level. And then I want to get granular and talk about some facts and figures around Alzheimer's disease and other dementias in Nevada specifically. I'd like to touch on some of our state policy priorities and also about the Alzheimer's Association and some of the services we provide. So, I know there are several doctors in the forum as a part of the forum, but I do want to touch on this because it's a question that's asked a lot. And so what is dementia and what is Alzheimer's disease? So dementia is an umbrella term that encompasses multiple forms of the disease. There's vascular dementia, Lewy body dementia, other forms of dementia, but by far and away, Alzheimer's disease is the most prevalent, accounting for 60 to 80% of all dementias. And so if somebody has a diagnosis of Alzheimer's disease, it is a form of dementia, but there are other forms. Oops, excuse me. All right, so some national facts and figures. There are more than 6 million Americans living with Alzheimer's disease right now, and that number is going to be going up rapidly. Currently there's 11 million Americans providing unpaid care for people with Alzheimer's disease. And I'll touch on this in Nevada specifically in a bit. And those caregivers provide an estimated 15 billion hours of care valued at about $257 billion. Many individuals who are diagnosed, who meet the diagnostic criteria for Alzheimer's disease, are not diagnosed by a physician. And so quite often somebody, may have the disease, but has never sought a diagnosis, never talked to a provider, nor have their family members. And so often they're not diagnosed. Fewer than half of Medicare beneficiaries who may actually have a diagnosis of Alzheimer's disease are aware of it. And that's because their provider has never told them, nor have they told a family member about that diagnosis. And so for some reason, that diagnosis is sometimes held away from the person living with dementia or Alzheimer's disease, as well as their family and caregivers. In the last 20 years, what we've seen is a decrease in deaths associated with other chronic conditions. Alzheimer's disease has seen an increase of 145% between 2000 and 2019. And so the death rates are going up as opposed to the death rates for other chronic diseases, which are going down, including cancer. And so 1 in 3 seniors dies with Alzheimer's disease or another form of dementia. Now, that may not show up in their death certificate. Quite often what happens is they'll die of another condition. For example, pneumonia, aspiration pneumonia, they'll choke on something. And so, it may be another direct cause of death, but that is certainly not the reason for the death. It's because of Alzheimer's disease. So the burden of Alzheimer's disease isn't shared equally amongst the different demographics across our nation. And so the burden to families is not shared equally as well. About 2/3 of Americans with Alzheimer's are women. Blacks are 2 times more likely than whites to have Alzheimer's disease or another dementia. Hispanics 1.5 times more likely. However, despite that disparity, 2/3 of Blacks, 40% of Native Americans, and 39% of Hispanics believe it's harder for them to get care for Alzheimer's disease or good care for Alzheimer's disease. In 2021, Alzheimer's disease and other dementias cost the nation $355 billion. By 2050, that will go up to more than $1 trillion. And this is an important slide because this is how the cost of Alzheimer's disease is shared amongst payers. So Medicare pays for a lot of the costs associated with the care of somebody with dementia. However, Medicaid has a huge share of that as well. Medicaid pays for all the long-term care services. Keep in mind, Medicare does not pay for long-term nursing home care or group homes or other kinds of long-term services and supports, but Medicaid does. And then the second largest share is actually out-of-pocket expense. So families that have somebody living with them, or they're caring for somebody, a loved one or a spouse with Alzheimer's disease or another form of dementia, a lot of that cost burden is out of pocket. So now some specific Nevada facts and figures. So if you look on the left in that purple block, 65 years and older, for people that old with Alzheimer's disease, there's about 49,000 of them living in Nevada right now. In the next 3 years, that number is going to go up 31% to 64,000. And it's the 3rd fastest rate of growth of Alzheimer's disease in the nation. We're followed behind Arizona and Rhode Island. The part of the slide on the right, which is orange, that talks about the deaths that occurred associated with Alzheimer's disease and COVID. A lot of these deaths occurred in nursing homes in 2019, and a lot of those patients had Alzheimer's disease. In Nevada, there are 2,167 people in hospice programs with a primary diagnosis of Alzheimer's disease. In terms of hospitalizations, it's one of the highest in terms of the rates of hospitalization. Hospitals use the term bed days, and so there's 1,711 bed days per 1,000 people with dementia, and that's extremely high rate. The cost to the state Medicaid program is very high as well, and there was a question about who pays for this. Well, about 63% of every dollar spent is federal on Medicaid. However, state government, the Nevada Legislature, has to come up with that other 37 cents on the dollar. And so a huge piece of this cost, $203 million in the cost of care for people with dementia, is paid for by state government and state tax dollars, not just federal tax dollars. It's also one of the highest costing diseases per capita. It costs Medicare about $37,000 per year for somebody with Alzheimer's disease, compared to about $21,000 per year for somebody without it. I think I'll skip over the rest of those numbers and talk a little bit about caregiving. And we've talked a lot about that today, about professional or paid caregiving. But there's a lot of unpaid caregiving. So here in Nevada, about 48,000 individuals provide unpaid care to someone living with dementia. Now, it's estimated that that accounts for about 78 million hours of unpaid care. And that could be a spouse, a family member, a friend, a neighbor. And that value, if you try to value it, is $1.3 billion a year in unpaid care provided by caregivers in Nevada. The other problem we have is that 80% of those who are providing care have problems themselves. They have chronic conditions or multiple chronic conditions. And a lot of them, because of the burden of caregiving to somebody with dementia who may have that disease for a long period of time, the caregivers themselves often suffer from depression. Mild cognitive impairment is a term that's used for sort of pre-symptomatic dementia. Sometimes it could be due to other forms of dementia or medical conditions, and sometimes it could be, often it's Alzheimer's disease. But About 10 to 15% of people who say they have mild cognitive problems go on to develop dementia. I've mentioned some of these already, but a couple of numbers I want to point out. And so in terms of the burden of care that's growing, or the gap in care that's growing, it's not only the personal care attendants or in-home attendants that where we're seeing a care gap develop, but it's also around trained professionals. So it's estimated, given the fact that Nevada's rate of growth of individuals 65 plus is the fastest in the nation, we're going to need an additional 267% increase in geriatricians to take care of those seniors in the next 25 years. In addition, people that diagnose dementia, generally, a primary care provider can provide an initial screening and make recommendations for a differential diagnosis, but that differential diagnosis of dementia is usually done by a neurologist and or a neuropsychologist. Can be done by a trained geriatrician. But Nevada, amongst 20 other states, is considered a neurology desert, meaning that we don't have enough neurologists to do the job. So there's a survey that's conducted every year by the Department of Health and Human Services here in Nevada. It's called the Behavioral Risk Factor Surveillance System. And there are 2 modules in that survey that are pertinent to the work that we do at the Alzheimer's Association. And one is called the Subjective Cognitive Decline Survey. And this cognitive decline survey asks people 45 years and older if they're having increasing problems, self-reported problems with memory, cognition, or that type of thing. And 1 in 7 people, age 45 and older, say they're having problems with cognition. Now, when you look at the age cohorts of these, it's interesting because 1 in 7, or 16% of people age 45 to 55, age 55 to 65, say that they're having problems. So even at a young age, people are starting to recognize that they may have problems. And that's not to say that someone self-reporting cognitive decline is going to go on to dementia, but there is a fairly high probability that they will go on to some sort of cognitive problem. The most important thing, I think, with this statistic is that of those people that say they have problems with cognition, less than half have ever talked to a provider about that, or a medical provider about that problem. And so that's why this disease goes undiagnosed for so often. Nearly a quarter of those with subjective cognitive decline in these surveys say that that it interferes with social activities, work, volunteering, other types of things. And 28% say they need help with household tasks. And that's a growing number. So given all of that, the Alzheimer's Association has a number of state policy priorities, and I'd like to touch on them. And we have 3 that we're highlighting, although we don't limit ourselves to 3 here in the state of Nevada. We can do more, but these are the 3 that we're looking at. We're looking to expand access to an early and accurate diagnosis, and that means augmenting the services that a neurologist and neuropsychologist would provide for diagnosis, but also training our primary care workforce to help with screening and initial diagnosis of dementia. And so we're proposing something called the Nevada Memory Network for that. And I'll talk a bit about that in a minute. The other thing we've touched on throughout today's meeting is the importance of caregivers. We talked a lot about paid caregivers, but we've also touched on the fact that there are a lot of unpaid caregivers. And we have to recognize the value that they bring not only to that person living with dementia, but also to state government, because they help offset the cost of Medicaid, keeping people out of nursing homes, which Medicaid would almost always pay for. Just to keep in mind, about 60% of nursing home beds in Nevada is paid for by Medicaid, which again is federal and state money. And so keeping people out of nursing homes is an important aspect of saving money, and supporting family caregivers is important to that end. The other thing that we'd like to do is to put a dementia crisis program in place. I had the privilege of sitting in on meetings between adult protective service workers, mobile outreach safety team members who are represented by law enforcement and social workers, county social workers. So over the last year, we've had this discussion through an ongoing meeting of a coalition to talk about what some of the issues are. And what they came up with was the fact that there's an increasing number of encounters between somebody who may have dementia and law enforcement or an emergency room. And oftentimes those end up with very negative outcomes. So somebody with dementia who's eloped from a nursing home or a family home is wandering on the street, is certainly upset. When a law enforcement officer sometimes encounters them, and you've heard about this in the news, including in Las Vegas recently, that person with dementia might act out. Acting out for somebody with dementia is just a form of communication, meaning I'm scared, I'm nervous, I'm in pain, I'm hungry, but they act out in certain ways. And not recognizing that, they often end up in an encounter with law enforcement that ends up in them being put in handcuffs, taken to either a jail, a hospital, or a psychiatric facility, all of which are the wrong places for somebody with dementia. And so we're talking about, and have some support for a program called Dementia Care Specialists. It was a program that's tested out of Wisconsin and has been implemented in 4 or 5 other states. And this provides a point of contact for law enforcement, county social workers, and others when they have an encounter with somebody with dementia. So this person is trained to help with de-escalation of that encounter, to help with crisis stabilization, and to provide ongoing community support to them, and if they have a family caregiver, to them and their family. And so we would really like to support dementia care program. So first, the Nevada Memory Network. And so again, this is based on proven work out of Emory University, the University of California, San Francisco, and the University of Wisconsin. And what we're looking at is enhancing our PCP screening and education to do dementia care screening. There are some programs across the state that are both our public schools of medicine that do that, but we want to further enhance that. We also want to establish clinics or hubs where diagnoses of dementia can occur. We've got 2 terrific hubs. We need more of them. That's the problem. One is up in Reno at the renowned Neurology Institute, and the other is in Las Vegas at the Cleveland Clinic Luruvo Center for Brain Health. And so we want to expand on their capacity to see more patients and provide more diagnostic care. We want to have a warm handoff to the primary care providers with a care plan. And we want to help that caregiver who may be involved understand that care plan. And then finally, we want a care navigator to help that patient caregiver dyad, those partners, to get access to community-based supports and ongoing services. And this is kind of a model of what we're talking about. So you can see the PCP here, the primary care provider, does an initial screening, sends it to the memory assessment clinic where they do a diagnosis. They develop a care plan for the caregiver and the patient, hand it back to the primary care provider, and then a care navigator is engaged with with the primary care provider and that household to provide ongoing community supports. We also talked about the importance of family caregivers. And so what we want to do at the Alzheimer's Association is to really enhance the work of family caregivers who are currently, most of whom are unpaid. And this is based out of work in Indiana, Georgia, Washington, Missouri, and a number of other states. And we want to improve the Nevada Medicaid Home and Community-Based Waiver program for the frail elderly. And this is done through providing additional supports and training for that family caregiver that's very specialized. We also want to make sure that that family caregiver has communication with the state case manager in these programs so that they can put notes into a case management system, and that case manager can know on an ongoing basis what's going on with that patient and can provide specialized training to that caregiver. And so we really want to make sure that the caregiver is getting as much support as possible. A couple other ways we want to make sure that that's encouraged is we want to make it easier for that caregiver, that family member, to get paid. Currently, Nevada Medicaid pays for that, but they won't pay for a spouse. And I can tell you a lot of caregivers, most of whom they're spouses, and they often give up their own careers in order to become a full-time caregiver to somebody living with dementia. And so we want to be able to pay them to be a caregiver. We also want to pay other family members or friends to be caregivers and make it simpler to do that. And then finally, what we want to do is we want to provide respite care to family caregivers. And we want to make sure that we're staying on top of their mental health and even providing a health coach to them so that they know how to deal with their stress as a caregiver, but also have access to respite services. I mentioned the Dementia Specialist Program. This is based out of work in Wisconsin. And I already discussed the fact that it provides crisis intervention, crisis stabilization, and long-term support to people. We also see this position as providing screenings and referrals out in the community. There are some excellent tools and new technologies that are being developed to do very accurate screening, at least at the level of dementia, not necessarily a specific type of dementia. And so screening would become an important role for these positions as well. A little bit about the Alzheimer's Association. Our vision is a world without Alzheimer's disease and all other dementias. And this is probably the most important slide. So we maintain a 24/7 helpline, 1-800-272-3900. And at any time of day, 7 days a week, you can call and speak to a licensed clinical professional about your needs. And so they'll help you with information as well as educational resources for caregivers. Our website, alz.org, also has a huge array of resources for caregivers and individuals in the early stages of disease. And so those are all free and online and available for people. All they have to do is access our website at alz.org/education. We maintain partnerships with a number of clinical research firms and agencies, including NIH. And so we have a program called Trial Match. And this allows people who are living with disease, but people who may not have any dementias, to be participants in dementia drug treatment trials. And we host the largest international scientific conference on Alzheimer's disease at the AAIC, the Alzheimer's Association International Conference. The Alzheimer's Association is the largest individual organization in terms of research funding, only behind NIH in the United States, the National Institutes of Health, in terms of funding research activities. And then, of course, we have our Walk to End Alzheimer's, our fundraising event. It's going to be in October in Las Vegas and also in October in the Reno-Sparks area. And that is it for me. Madam President, I will stop sharing my screen. I'd be happy to answer any questions.
Thank you so much for that presentation. Forum members, any questions?
Yes, Madam President. Lucille Aiden have a question.
Go ahead.
I have, I have like a number of questions here, but they all might be related. And my first question then is, why is it such a growing pandemic now, Alzheimer's? And what caused it?
Well, thank you, Lucille. That's a wonderful question.
Mm-hmm.
For the record, my name is Charles Duarte. I think there's a combination of factors. One is our aging population. Mm-hmm. For a long time, we've seen this increase. The baby boomer population, and so one of the major factors that contributes to Alzheimer's disease, it's not necessarily just genetics, but it's actually age. And so when you break down some of the factors associated with the risk of Alzheimer's disease, number one is age. There are other factors like education and social engagement, physical activity, and then of course genetics, but age is a part of it. So with our growing population, there's more frequent issues with dementia. The second is, historically, this is something that's not been diagnosed, or people have resisted getting a diagnosis. Mm-hmm. I think more and more, and thank goodness for this, through awareness campaigns, people are asking their doctors about it. Mm-hmm. And doctors are more willing to provide the screening that's necessary and refer them for a diagnosis. And so I think that's another reason why we're seeing an increase. The third reason, I think, has to do with lifestyle. Mm-hmm. There are risk factors associated with diet or lack of diet, or poor diet, lack of exercise, other types of risk factors like drinking, injury to your brain, other types of factors that contribute to the risk of Alzheimer's disease. And so now we're just recognizing it. One of my colleagues says Alzheimer's disease is a disease of middle age that you only see in old age. And so those kinds of lifestyle factors in middle age can have an impact, but later on in the form of dementia or Alzheimer's disease. I hope that answers that question.
Yes, you did. Thank you.
Dr. Wan?
Thank you, Mr. Duarte. That was an excellent presentation. I have one question and one comment. First, the question is that you mentioned that so many people are hospitalized with Alzheimer's disease. So I understand that you obviously you can have physical disease, all kinds of problems that Alzheimer's manifests, but there are some people that just have Alzheimer's disease and they don't necessarily need to be hospitalized. So I'm wondering if you can save some resources if some of these people they've got a diagnosis and they have Alzheimer's, say, but they don't need necessarily to be hospitalized. My other comments, I think you made an excellent point on the factors of because we really don't know the cause of Alzheimer's disease. There are ongoing studies, high-end research using MRI and physiological imaging of the brain, but we really don't know the cause of Alzheimer's disease. But one of the huge factors is lifestyle too, and you pointed it out. It's exercise. It's actually it's hard to show the proof of it, but it's pretty well shown that if you exercise on a regular basis, you decrease your chances of developing dementia, Alzheimer's anyway. And so that is really an important issue, that the lifestyle issue, because one of the worst things you can do for your health. Everybody knows how bad smoking is, but being a couch potato is maybe just as deadly. And not exercising is not only terrible for your physical health, but it's really bad for your mental health. So we have a community that engages on a regular walking basis, and I think it really shows that it really helps the whole community and the society if you just stay healthy. Thank you.
Well, Doctor, thank you for that question. So to maybe piggyback on your comment and then answer your question. Yes, and in fact, social engagement is one of the factors that really contributes to a lessening of the risk of Alzheimer's disease. So the fact that you mentioned, a group walking club, essentially, that does two things, right? That creates social engagement opportunities for people to talk and maintain that kind of those personal relationships, as well as exercise. And both of those contribute to the lowering the risk of Alzheimer's disease. With respect to hospitalizations, I'm not an expert in those statistics, but I can tell you from some of the data that I've seen, a lot of those hospitalizations are secondary. So they're secondary to things like behaviors. And so, somebody is demonstrating a risky behavior in a nursing facility, they may get admitted to a hospital to treat them for behavioral issues, and oftentimes they end up getting over-medicated, or other chronic conditions. But Alzheimer's disease, particularly in the late stages, will result in individuals who may have problems with falls, another increased cause of hospitalization, as well as pneumonia. And so all of those they may be secondary, but they're really not secondary, because it's really Alzheimer's disease that has been the primary contributor to those issues occurring, and the hospitalizations as well. So Alzheimer's disease in itself doesn't necessarily result in hospitalization. Oftentimes people pass away peacefully at home or in a nursing home, but it's those other secondary things that occur because somebody cannot eat properly, cannot ambulate, cannot toilet, cannot do a lot of things without good support, and oftentimes that ends up in injury or disease.
Thank you. Dr. Jordan?
Yes, thank you for your presentation. For the record, my name is Marilyn Jordan. My question comes from some of your data that says that we are a neurology desert. I looked this information up, and it's projected that by 2025, we're going to have 128,000 people suffering from this serious disease, but only 97 possible neurologists throughout the state. what's your organization or what is the state of Nevada doing to recruit people to help us attack and work with the members of our senior citizens in Nevada to reduce this problem?
So in terms of what the Alzheimer's, thank you again, Doctor, but Charles Duarte for the record. In terms of the Alzheimer's Association, we work on policies that help support the increase in access to an early diagnosis. And so I mentioned the fact that one of our policy priorities, and I hope to have some legislation around this in the next session, is to get some funding to support an increase in the number of neurologists and neuropsychologists in Nevada. Now, neurologists and neuropsychologists are not dime a dozen. They are really difficult to recruit. And so, we don't hold out hope that we are going to be able to bring in neurologists and neuropsychologists to the state. But what we're really hoping to do is to augment the training that we provide to PCPs to help with those diagnoses. A medical director at the Cleveland Clinic Lou Ruvo Center told me that he firmly believes that 50% of the diagnoses that he makes for Alzheimer's disease can be done by a trained primary care physician, a family doctor. And so I think if we're going to be looking at bringing in resources, it really has to focus on that primary care home for people. Again, we're trying to bring in resources through legislation that I mentioned, the Nevada Memory Network. But again, that'll cost money. That'll be an investment, and we'll see if the legislature wants to make that investment. What the state is doing is, honestly, they're trying. They have loan repayment programs, and if you're a geriatrician or want to be a geriatrician, you can apply for loan repayment programs. And then the Board of Medical Examiners does encourage physicians to get training in dementia and Alzheimer's disease. They have a program that the Nevada Legislature passed in 2003 that allows for every 2 hours of continuing medical education to count for 4 hours, continuing medical education in Alzheimer's disease or dementia to count as 4 hours of continuing medical education credits. So it's not much, but that's what the state is doing as far as I know.
Thank you.
Oh, if I can mention a couple other things. Our 2 schools of public health have done a really good job of trying to increase the number of residents that go into the fields of geriatrics. And they've got grants from the United States Health Resources Services Administration and to support this activity of increasing the number of geriatrically trained physicians. And then up in Reno, we've got something called Project ECHO, which is an online webinar-based training program for primary care providers around dementia care. And so that happens 2 to 3 times a year, I believe. It's a 6-week course for primary care providers. And so there's other activities going on, particularly through our public schools of medicine, to train primary care practices or providers.
As for 8 neurologists, they'd have to deal with 10,000 people. That's an awful big number. And
It's
so
a big number.
I feel that that's something that we should pay attention to. Yes, we have an increase in the number of folks experiencing that and all aspects of the different kinds of dementia, but we need to have some people that are able to diagnose it. And as you said earlier, we don't have people getting diagnosed, so a lot of people are walking around with the possibilities, but nobody to help them.
Right, exactly. And I think that becomes an important issue. That becomes a really important issue when we start looking at drug treatments that are coming down the pipeline through the FDA. So there are a number of clinical trials of new drugs. One was recently approved by the FDA, although I think in some fields, some folks feel that it had a minimal impact and only an impact on delaying Alzheimer's disease for those in the mild cognitive stage. But there are other drugs in the pipeline. And to get the drug, you have to have a diagnosis. And to get a diagnosis, you have to have a specialist look at you. And so I think that pressure is going to be increasing to have those types of fields, specialties and training expanded. But again, I think we cannot discount the use, the importance of our primary care physicians and other practitioners in helping with that diagnostic work.
Thank you so much.
You're very welcome.
Thank you. Mr. Troth?
Thanks, Madam Chair. Charles, excellent presentation. I got a series of questions here, so
sure.
Bear with me. On your,
I'm going to take notes if you don't mind, because
what's that?
I want to make sure I catch your. I'm going to take some notes so I can catch your questions.
Yeah,
sorry.
I'll make sure I go so long. Yeah, Roger Trotham, District 8 here in Clark County. On your Nevada priorities, on the third one, fund dementia care specialists. Let me, first of all, any idea what that would cost? Is the first comment question.
Yeah. Based out of the, thank you very much for the question. So again, Charles Duarte for the record. Based out of the work in Wisconsin that I've been able to look into, it's about $100,000 a year per each position. It includes things like, access to equipment, benefits, etc. What we're talking about here are master's level social workers, not clinical social workers, but master's level individuals in a health field, most likely social work. And so each position would probably cost about $100,000 a year. But again, if they can delay the onset of our placement in a nursing home by 18 months, they would save tens of thousands of dollars a year per person if they can delay that placement and keep people living a good life in their communities.
Okay. Next question then, you're advocating for that to be government money of some type?
Yes, that's correct. Yes, that's correct.
Okay, next question would be, do you think the Nevada State Legislature has an appetite for something like that?
So very good question. Oftentimes people look at a piece of legislation, and if it has a dollar amount attached to it or a cost, they shy away from it. But again, I think they have to look at the alternatives. And what I presented before was that the Nevada Medicaid program, which is partly funded, and not an insignificant amount, funded by legislative state dollars. They pay $233 million a year for dementia care, and 1/3 of that is state dollars. Now imagine if we could avoid even a small percentage of that by investing in these types of positions. I think it could create tremendous cost savings, which is why a very conservative state like Wisconsin and Georgia have invested heavily in these positions, because they do recognize that it saves money in the long run. It saves the state money in terms of inappropriate hospitalizations, Medicaid costs. And so it's an investment, but it does have cost savings, and it avoids future costs.
Okay, a follow-up question to that, is your organization lobbying this next session for for that particular concept?
Well, I'm not the lobbyist yet. I'll be registering as a lobbyist during the legislative session, but the answer is yes. We are going to be asking for this. I'm currently talking with the Nevada Aging and Disability Services Division to see if they can include the Dementia Care Specialist Program as a part of their budget. I have a meeting with the Director of Health and Human Services, Richard Whitley, on July 5th to talk about this. But the Commission on Aging, the Nevada Commission on Aging, has also recommended these positions as a part of their legislative priorities in the next session. So hopefully we'll have a legislative sponsor or a committee sponsor to move this forward.
Thank you, appreciate that. A couple more. Going to the family caregiver waiver discussion. Does the legislature going to have to work, and is it going to be a state, and is it a federal issue to allow spouses and guardians to receive pay for caregiving? Am I making sense on my question?
Yes, absolutely. Yep. So again, Chuck Duarte for the record. Under current Medicaid regulations, spouses and guardians are considered legally responsible individuals are precluded from being paid. However, many other states have passed waiver programs. These are Medicaid waiver programs. And what a waiver is actually the state going to the Secretary of the U.S. Department of Health and Human Services and say, Secretary, we want to waive certain federal regulations to make sure we can provide a program that's appropriate for the people in Nevada. That's what a waiver is. And so other states have requested the Secretary to waive those requirements and allow legally responsible individuals, i.e. spouses and guardians, to be paid caregivers, paid family caregivers. So at the federal level, there's one recognition that has to occur, and that can be done in a process that Medicaid does called the state plan change. The legislature can choose to recognize that through legislation. And so what we're asking is for the Nevada legislature in the next session to sponsor a bill, to move a bill forward that would create the opportunities for these structured family caregiver programs to be developed and to allow spouses and guardians to be paid caregivers. And so the Commission on Aging is moving this forward as a recommendation. We have a possible bill sponsor who wants to carry this bill into the next session. We believe that it will have either a cost savings or a minimal cost. And so we're hopeful that this will move forward in the next session.
Thank you. I appreciate that. Good answers. One last question. This is about your organization, the Alzheimer's Association. I think we need more of these types of groups that do different things. Can you give us a little bit of an idea of how your organization is funded, where you get your money to continue? I know you fundraise. Are you getting other supplements from other corporations or state government agencies to fund your association?
So thank you for the question. Again, for the record, Chuck Duarte. The vast majority of our dollars come from donations. And so we raise a lot of money through our activities, including our Walk to End Alzheimer's. We had an event yesterday called The Longest Day. And so a lot of our operational costs are funded by those types of activities across the nation. We do apply for state grants, and some of those grants do support some of our services. For example, here in Nevada, we have the privilege of getting grant funding from the Aging and Disability Services Division to provide vouchers to family caregivers so they can pay for respite and take a break from caregiving. So that's an example of the type of grants that we do. The other thing that we do is we provide research dollars, and most of our research dollars come from donations. And so we use those dollars to help support research activities at the NIH as well as private research institutions. Less than 1% of our money comes from like big pharma, big pharmacy companies. And so we really try not to be obliged to organizations that may be seeking some sort of quid pro quo from the association, some sort of endorsement for the work that they're doing. And so we really try to keep those requests to a minimum. So most of our dollars come from donations, as well as grants that we get from states across the nation.
Thank you very much. Appreciate your information.
Thank you, Mr. Duarte. Ms. Laughlin, you have a question?
Yes, thank you for that informative presentation. Mr. Duarte, I had one question, one comment. I'm thinking about the neurology shortage, and glad to see some creative problem solving here, because I suspect that it's not even just a matter of recruiting. I suspect there's a shortage of residency programs in the nation. So I don't see how we'll even be able to, as a nation, get the number of neurologists through our, get the number of neurologists we need without more residency programs. So I'm glad you're looking at new ways to diagnose this. And then my other was just a point of clarification, because I was really struck by the increase in Alzheimer's deaths, disease deaths, and you may have started to touch on this. So explain to me how you die from Alzheimer's as a primary condition, or is it that Alzheimer's is not being diagnosed as the primary condition and it's something else secondary is what's killing them that's associated with the Alzheimer's? So the statistic was so huge, I was like trying to understand it.
So again, Charles Duarte for the record, and I'm not an expert in this data, but I can tell you what I've read and what the association has published around the increase in death rates associated with Alzheimer's disease. And so both of the points you made are correct. There's an increased number of individuals who are getting diagnosed, who go into the hospital with Alzheimer's disease, or a nursing home most likely, with a primary diagnosis of Alzheimer's disease and die as a result of the disease itself. The disease is fatal and it is progressive. And so the disease will result in the inability to eat, the inability to do a lot of different functions. And so that in and of itself will result in death. The fact that they can't take in water properly, can't eat, will result in starvation and death. The other very common problem is something called aspiration pneumonia, which is the result of the inability to control your swallowing and control your drinking. And that's a brain function. And so it results in food and or water and bacteria getting into your respiratory system. And so that's a really major, large cause of death rates associated with Alzheimer's disease. And again, so we've got increasing diagnosing of Alzheimer's disease, albeit it's still not at the point where we'd like to see it. But also the fact that Alzheimer's disease greatly contributes to these kind of secondary factors such as failure to thrive, inability to eat, and aspiration pneumonia.
Thank you for that. I think many people would be surprised by that, but it makes sense. The brain is the function of everything in your body. So if you can't eat, you can't swallow, you can't live.
Madam Chair, this is Lucille. I have a question.
Yes, go ahead.
The presentation was very informative, but what I want to know, what are the signs and when do you think one should be evaluated to get this diagnosis? Because, I'm forgetful now, and I was wondering, is that one of the signs of Alzheimer's?
Well, thank you for that question. Actually, it's a very important question and an extremely common one. The Alzheimer's Association puts out a presentation for lay people. It's called the 10 warning signs. And in that presentation, we really make a distinction between what's normal aging and what could be problems caused by the early onset of dementia. And so the fact that, you forgot your keys twice this week someplace doesn't mean that you have dementia. The fact that, I can't remember somebody's name that I just met 2 minutes ago doesn't mean I have dementia. But increasingly, if you have problems with cognition, with memory, thinking, executive functions like reasoning that become more and more frequent, it's important you talk to a family member, to a spouse, and ultimately to a provider. So it's really something that is cumulative. And again, the association puts out an excellent educational program for lay people called the 10 warning signs. And that really can help an individual make that distinction between what is normal aging and what could be, not necessarily is, but could be the early signs of dementia.
Thank you. I needed to know that.
And go to alz.org/education, and 10 warning signs are right there.
Thank you. I do have one question. You're talking about pay for family members, caregivers. Will that be based on income because anything Medicaid is usually based on income.
So to answer your question, again, Charles Duarte for the record, it would not be based on so let me back up a little bit. Medicaid eligibility would be for that patient, the person receiving care. And so that's based on income. However, if a spouse or guardian is providing care, the Medicaid program can set up criteria by which to pay them. And that could include income. However, in other states, what they found is that most often a spouse or a guardian, or even, a daughter-in-law, a daughter, whoever it might be, they have to give up their careers, their time in the workforce to be a caregiver because of the disease. The disease progresses to the point where it goes from, mild to moderate to extreme. And as that disease progression occurs, the individual is going to ultimately need almost 24-hour care. And so the ability of that person to provide in-home support and get paid for it is the fact that they probably happen to give up their job. Now, some states like Missouri, what they've done is they say you can't be working outside the home in another role if you're a paid family caregiver. So some states have set up that criteria that, if this is going to be your job, we'll pay you, but you can't be doing, 3 other jobs on the side. So there's criteria that could be developed.
Thank you so much. I just have one more comment. I have friends who are spouse caregivers. What they really would like to have is one day off. And I don't know if that's like we were talking about the home health care, or if it would work into this program that you're talking about being paid. But just to have someone to come in one day so that they can have a day off, to do what they have to do. I don't know if you've considered anything like that in your legislative priorities.
Yes, absolutely. So there's 2 things I can comment on there. One is with the proposal that I talked about today, the structured family caregiving proposal for Medicaid. An important aspect of this is that the caregiver, him or herself, is in contact with a state social worker who's monitoring the condition or the needs of that person, including respite. And so what we recommend, and what some states have done, is to say at least one day a week, they're getting someone to come into the home, or they're paying for that person to be taken outside the home to something like an adult daycare facility, so that that person, that caregiver, can have respite, can maintain some sort of social connection, can do the work that they need to do to maintain their households, whatever that case might be. So the answer is yes on the Medicaid program. Currently, the state of Nevada Aging and Disability Services Division pays for respite for people who may not be taking care of someone on Medicaid, but they have voucher programs. And again, the Alzheimer's Association in Nevada is a recipient of those grants. And what we do is we administer them, and we provide vouchers to people who are caregivers, and the caregiver can then pay for somebody to come into the home and give them some respite or relief. Or they can pay for the patient to go to an adult daycare facility for that day so they could still have respite. So the answer is yes, that's an important aspect of helping caregivers do their job, because if not, their mental health and their physical health will suffer, and they will diminish in their ability to be a caregiver.
Mr. Toth, you have another question?
Madam Chair, sorry, one more question. Charles, you sat through some of the previous presentations we had, and it sounds like you've been doing this for a long time. What's the private sector business type things going on out there? Is this, we know that in healthcare itself with aging populations, there are some expansions and a lot of things are going on. What are some of the things that are keeping, private industry, and obviously they want to make a buck and they need to be profitable. What's keeping them from, progression and growing and making some of that available through insurances, whatever we do as an American, as a citizen or a person to try and find health care for some of these things? Because we talk about all the time government funding. And I just have a concern about that becoming the only answer. What are some thoughts that you have on some of that?
So, in a prior life, I actually was a marketing director for a Blue Cross Blue Shield plan and sold long-term care plans to people that Blue Cross and Blue Shield had developed. And I can tell you, and I think Tony Archipedin, who testified in public comment earlier today, she hit the nail on the head, and that is that the private sector, particularly the insurance market, has not been able to really provide a sustainable solution to long-term care needs of families, a private sustainable solution for long-term care needs of families. Oftentimes if you have to buy a long-term care policy, you have to buy it when you're very young, you get medically underwritten, and then if you buy it when you need it, of course, then it's unaffordable. So the markets themselves haven't responded well or haven't been structured in a way that insurance can take care of it. In terms of private sector providers, I think the unfortunate thing is that private insurance companies do not pay for long-term care services, period. Neither does Medicare pay for long-term care services. And so when you look at the fact that these services are really not part of the employer-sponsored healthcare model, the insurance model, it really leaves just two significant payers. One is Medicaid, because that's Medicaid's job. Medicaid's job is to provide long-term services and supports for people who can't afford it. And that's their mandate by Congress since 1965. And so, fortunately or not, private sector insurance model has not been able to address long-term care. Congress did in 1965 with the establishment of Medicaid. So again, you're really talking about a sector of the healthcare market that is going to be predominantly funded by government-sponsored programs for now into the future, unless there can be some solution on the private sector side, and I've not seen any in the 40 years that I've been working in this business. So the answer is yes. Now, to make it so private entities can provide, we were talking about a lot about personal care attendant services. And again, to be clear, a personal care attendant is somebody who has some training, goes into a home and helps people with activities of daily living, bathing, toileting, dressing, grooming, ambulating, but also other types of activities like chores in the house, cooking, shopping, etc. And again, when you look at the payer for that, there's two payers, out-of-pocket costs and Medicaid. Private insurance, long-term care insurance, pays for some of that, but it's a very small percentage. And again, people can, only a percentage of the population can afford long-term care insurance. And so it really ends up being Medicaid and out-of-pocket costs to families. And I can tell you from the caregivers who are part of our programs, former caregivers whose loved ones have passed away from Alzheimer's disease, they tell me that it's bankrupted them. It's interfered with their ability to earn a living. It's disrupted their careers. And so our ability to support them is extremely important as a way of reducing state costs and federal costs by investing in those programs. And again, it is going to be an investment of state and federal dollars. But if we invest $1 up front in some of these measures, we're going to save tens of thousands of dollars on the back end. So again, it's a cost-effective strategy. But again, like I said, in the years that I've been involved with this, I've not seen substantial private sector solutions. I mean, there's solutions in other nations. Most of them involve some sort of taxing authority to fund a long-term care program for seniors. But again, you're talking about, you know, a nationalized program. Japan is one country that comes out as an example, but there are many others.
Mr. Duarte, thank you for the work you do in Nevada on behalf of Alzheimer's Association. We appreciate the information you have shared, and thank you very much for your presentation and your time. Thank you.
Thank you very much for the opportunity, and my contact information is included in the presentation, and I'd be happy to receive any emails or phone calls from you folks if you have subsequent questions. Thank you.
Thank you again. So, forum members, we're going to move on to agenda item 7, the facilitator reports concerning issues of importance to seniors. Before we have Ms. Aden and Ms. Tyler do their presentations, I'm going to ask Ms. Jordan if she has anything.
Thank you so much, Madam President. During the course of this past month, we've spent a great deal of time, both Ms. Tyler and Ms. Aden, in chatting about what we could do. We looked into a number of the agencies throughout Nevada, and we came up with a very interesting list that we have 85 independent living facilities. We have more than 160 assisted living facilities in our state. We have memory care facilities, 73. We have nursing home adult care, 11. We have 35 centers for hospices and 68 respite care facilities. And surprisingly enough, many of these facilities are unavailable for visitation or discussion due to staffing issues, but mostly due to COVID restrictions. So many of the facilities are on lockdown, and it's really difficult to be able to go and visit. I was able to talk to maybe 10 different facilities and ask what they consider to be their major challenges for long-term care. And the following were examples. An increasing aging population. Number one was staffing shortages. There were a tremendous number of staffing shortages, and many of the staffing shortages are due to turnover and poor salaries. An issue that I thought was most interesting was the overall quality of care. If you have 5 people with 1 staff person and you elevate to 15 or 20, that's not going to be quality of care. The integration of services was also an issue. When somebody moves from one place to another, or they move from independent living into skilled nursing, there's a lack of coordination. So that seems to be very, very an issue that needs to be addressed. And the financing cost, of course, is always a care cost. So those are some of the things that we discussed, that I had information from the different centers. And I look forward to asking the members of the forum that if they have an opportunity to visit any of the centers or in touch with any of the centers, to please fill us in on some issues that might be relevant, some of the care services that members in the facilities want addressed, so that we can pick up and move forward on some of them. Thank you very much, Madam President.
Thank you. We'll hear from Ms. Aden, our Northern Facilitator, first. Ms. Aden, do you have anything for us?
Well, I have a couple of things I'd like to bring to your attention. Since there are only 2 members from the North that I've seen, that participated in the forum. I didn't know where to start on this task, so I took it upon myself to call nursing homes and visit a couple of them, and I had the same problem. You can't visit most of them because of COVID, and the one I had a problem with, I brought up in the meeting today earlier. That was Little Angels. They have a problem there. And Cascades have COVID, so they can't visit them. And what I think we should do, we should all come up with the proposal that we would like to present to the legislature that we want to pass regarding the health care of seniors. So that's something I think all of us need to think about and come up with some kind of suggestions so we can go over them and have something to present to the legislatures. That's all I have, Madam Chair.
Thank you. Thank you very much, Ms. Hayden. Ms. Tyler, our facilitator in the South, do you have anything for us today?
I visit my senior center quite frequently because I go there to exercise. One of the main points that they pointed out to me is the long-term care costs and insurance and things of that nature. Also, it was brought to my attention that Medicaid, even though they do pay, say, a certain amount, that they actually can put a lien on the senior's home. And the question came up, well, what happened with the spouse? They, they're still there. But those are really troubling issues when it comes to long-term care insurance. Apparently, it's just not an available option that you're able to say keep your property or things of that nature. Another thing, too, is the definition, say, of long-term care. How long is long-term care per se? Is it short, intermittent, or really long, say for years, for example? And if the senior plan to return to their home at some point, I mean, you can be in a skilled nursing facility for a year and go back home, but if your home is already taken, and I use the word taken, but they say no, it's not taken. It's actually they put a lien on it. And whatever money they have actually spent out, they actually take it back. Well, what that does for the family as well as the spouse. The other issue, I got an email from Mercedes Maharis. I don't know if she's there or not, but she says she did visit a few facilities in her area, and one senior citizen center actually closed because of the lack of participation. And she said they was actually changing the centers to active adult centers. And she also mentioned several other concerns, which we are already working on, or talking about, I should say. The rising cost of health care, and that basically includes long-term care facility. Utility costs, food costs that's rising, gasoline that's rising. Everything is rising, but the benefits, say, for your Social Security. Also, senior transportation. Apparently, there's a problem with senior transportation, getting seniors backwards and forth to the community centers and other places. Uber and Lyft drivers and things of that nature prefer, out-of-town visitors or businessmen or something of that nature. They avoid actually, coming to certain areas or providing certain services. So those are the things that she mentioned that she would like us to look into.
Thank you so much, facilitators. Members, does anyone have any comments or anything to add?
Mercedes Maharis.
Yes, go ahead, please.
I also found out that the only center in my district is very concerned about what will happen when people can't ambulate anymore. And I don't have the answer to that. They do have 100 people a day plus minus at the one center in my district, Senate District 3. And I think that a concern is that this may eventually close down itself. And I hope not. Thank you. Can you hear me?
Thank you, Ms. Mercedes. With that, we will move to agenda item 8, which is public comment. We will start with public comment for those in the physical locations and then move to public comment for anyone who has called in. Please remember to clearly state your name for the record. Is there anyone in Carson City who would like to provide public comment at this time? Hearing none, is there anyone in Las Vegas who would like to provide public comment? I see no one here. Staff in our broadcast and production services, please add the first caller with public comment to the meeting.
If you would like to give public comment, please press raise hand in your Zoom window or *9 on your phone to take your place in the queue. The public line is open and working. However, there are no callers wishing to testify in public comment.
Thank you very much. We will close public comment. Are there any comments from the members before we adjourn? Seeing none, I do have a couple of comments. We have seen and heard during our meetings a lot of information about seniors, senior living. I think some of these programs, presentations have resonated with some of us. So what I would like is for the forum members to possibly go back through the presentations, pick out something that you feel we would be able to have the legislature enact, something that would enrich the lives of seniors, and bring that to the next meeting so that we can begin to discuss what we are going to ask for our BDR. Next session or next forum meeting, we're going to hear about how seniors are being scammed and what can be done about that. So that concludes our meeting for today. Our next meeting will be Thursday, July 14th, 2022, starting at 10 a.m. This meeting is adjourned. And thank you all very, very much for your questions and observations. And I will see you in July.